It is my pleasure to introduce our distinguished chairperson, Dr. Adil Rai, and our esteemed speaker, Dr. Narendranath Samantre, for the workshop titled Advances in Exposure Therapy for Anxiety Disorders, Harnessing Inhibitory Learning and Others. Dr. Adil Rai is the Deputy Commander, Indo-Tibetan Border Police Force. He holds an MBBS and MD in Psychiatry from Armed Forces Medical College as well as in DNB in Psychiatry. His areas of expertise include addiction psychiatry and stigma in mental health. He has also been recognized with the Charu Shiva Award at the annual National Conference of the Association of Industrial Psychiatry of India for the best research paper in behavioral sciences. As well as our speaker, Dr. Narendranath Samantre is an assistant professor at NIMHANS and holds an MPhil and PhD in clinical psychology. His research and clinical work primarily focused on anxiety disorders. His contributions to the field have been widely recognized, and he is the recipient of the GC Boral Award for his outstanding work in the discipline. Please join me in warmly welcoming Dr. Adil Rai and Dr. Narendranath Samantre to the stage. Thank you. Please.
So, yeah, no, it's fine. Very good morning to one and all. I hope, no, I was hoping in the, it's since the session is a 9 to 10, I must be ending up only speaking with the chairperson, but still this number is there. I'm happy. Okay. So, to begin with my sessions, so what I'd like to do is that, so think about two scenarios. Two scenarios, right? First scenario, imagine that we all are hostelers. Imagine that, okay? And खाना तो अच्छा मिलता नहीं है hostel में, so presumably that is a common thing. So one invitation is there, party. So you had build up your fancy imagination. Today जाके तोड़ फोड़ करना है, खाना तो भरपेट खाना ही खाना है. And you went to the party and you had the food as per your expectation. What you expected, you got it. Fine. Let's imagine the second scenario. After 7-8 days, another invitation came. Same craving was there. Same expectation was there inflaming up your mind, and you went to the party. But when you reached to the party, it was a disastrous experience. It was nowhere your expectation. You said, "Yeah, I could have stayed back in my hostel. Why to wasted 2 hours coming and going? कुछ देना भी पड़ा वहाँ पे formality के लिए." So now my question is to both of you. I mean, sorry, to all of you. Among these two events, which is more likely you're going to retain the memory for a longer period of time? First or second? Right? Second. So hold this at back of your mind. I'll be coming to this example later on, but this example is a crucial to the point I'm going to make it during my presentation. The second memory you will retain for a longer period of the time, and scientifically that is also the right. Anyways, we'll move on. I'll come back to the later on. So it's a couple of minutes maybe of a revision of the things that we already might know very well. It's about that, the predominantly the exposure model, the based on a theory that is known as emotional processing theory, EPT. I won't go to the details of that. So basically what you need to collect, the basic information from that is that, first thing, what are the feared event? What events you are actually one is scared of? It may be social situation and social anxiety, maybe a phobic object during any kind of phobia. In panic, it may be kind of unexpected fear, or basically a fear of going to die. Or in OCD, a lot of other things are there. So first you need to elicit the what exactly the feared cues. Then you are going to elicit the feared consequences attached with each of the cue. What exactly are the feared consequences? And thirdly, you need to know what are the coping behavior the patient does in those kind of specific feared events before coming to the therapy. So that may be wide range of neutralizing behavior in compulsion, the form of compulsions, or it may be avoidance, the mother of all coping strategies, or it may be, say, for example, any kind of safety behaviors. I'm not going to narrate all those things. Those are the basic stuff. These are three things we're going to elicit in details, either through interview or with certain kind of questionnaires. That is fine. After that, what we need to do is to arrange all the feared cues in kind of a particular hierarchy. Then we're supposed to start from the medium item to elicit the anxieties. That is how the predominantly model of EPT for best exposure therapy has been done. Obviously, it has to be graduated, repeated, prolonged. I won't go into details of that. But this predominant model, again, we have moved beyond from the habituation there, but still, the basic criticism has been found that using that exposure model, even after 30% peoples are considered to be non-responders. Even if those who respond to those kind of things rest, even 50 to 60% do have relapses. The first 30 to 40, up to 30% are non-responders, and even if those who respond, among 50 to 60%, they do have relapses. So people wanted to know what they could more better do in terms of this exposure therapy so that at least they will mostly control this relapse part. This is where during 2008, certain theorist, the lead theorist of this model known as Michel Kraskip started to view something known as inhibitory model. So that today I'm going to share how using the inhibitory learning model, we are going to design the exposure therapy which is beyond EPT model. So this is the background. So what exactly in the little bit 1 minute more about EPT, emotional processing theory based model. What it does is that, what it focuses is that if there is certain feared cue, phobic cue, OCD related cue, whatever, we expect that threat expectancy is going to happen. I mean, I'm expecting if I'm going to panic, I'm going to die. If I'm going to touch these things, I might be having a disease. If I'm being in a phobic social situations, I might be rejected. If I end up in a loop, I might faint and die. So there are certain kind of feared cues that is associated with the threat expectancy. So those are predictor of threat. So what in the EPT model says that during the part of exposure therapy, we're trying to erase these connections. We're going to trying to delete these connections. This is the predominant concept of EPT model. Okay. But what these people in limited learning theorists propose that actually nothing gets erased from the memory. It is there. It always there. What might be some chance that during the exposure therapy, one additional learning does happen, and that is non-threat expectancy. This feared cue is not necessarily predictor of the things that I'm thinking. So it's another additional parallel memory always stays in there. It might be fact that this non-threat expectancy, when it is highly dominant, will have not much fear. But when during a memory this threat expectancy is dominant, probably will have more fear. But thing is that both always stays there. Never it gets erased due to the therapies. Now coming to the clinical translation, to make it more easier, before the exposure therapy, the patient is expecting threat. Okay? Understood? During the exposure therapy, we're trying to develop non-threat expectancy. Understood? So after exposure, what is going to happen? Two things. Either there'll be fear or either there'll be no fear, depending on which part of the memory is more dominant. If threat expectancy is more dominant, there'll be more fear. If non-threat expectancy is more dominant, there will be no fear that point of the time. But what is the factor that determines which part of the memory is going to be more dominant after the therapy? That's the $1,000,000 questions. What are the factors? So coming to that, having a discussion on that, See, the threat expectancy, the memory related to non-threat expectancy are highly context specific. It gets tied to the learning, tied to the context where the learning has happened. For example, we might have done most of the exposures at maybe a clinical setup or as a homework session we might have given to the therapist client's home. Okay, sorry, not therapist, client's home. What happens if, for example, he goes to a nearby OCD patient, for example, he goes near to be any kind of different multiplex where he is exposed to the washroom that he was not previously encountered. The chances are high that memory related to threat expectancy might be more dominant at point of the time. Or say, for example, he has gone to a different city, maybe for some interview like this conferences, where he is not exposed to beforehand. The memories related to the threat expectancy might be more dominant at point of the time. So that is a one problem associated with memories related to non-threat expectancy. It's not context specific. It's tied to the context. It's not generalizes. But the earlier learning is like a jungle fire. It has already generalized to a lot of different places. Second concept, second a part of it, the concept of spontaneous recovery. Say, for example, the patient, maybe a claustrophobic patient, during your therapy, what you did is that you made him practice inside the lift. Okay? He went back to the home where he didn't have the lift. Say, for he was in a semi-urban area or a rural area where the exposure to the lift was not much there. Suddenly, after 6 months, he's again exposed to the lift because he has not practiced or he has not practiced for the last 6 months. The concept here that the non-threat expectancy would be more dominant. Sorry, threat expectancy would be more dominant there because it's not practiced. That's a concept of spontaneous recovery, return of fear, to be very simple terms. So that is also a problem associated with memories related to non-threat expectancy. Coming to the third component is reinstatement of fear. So what is this reinstatement of fear? Say, for example, the patient is, fearing about, say, for social anxiety, about criticism from the audience or criticism from the senior faculty. Actually, that happened. What the patient is fearing, that actually those things really happened with the patient's life. So in that case, in those he got a disease or anything XYZ. Whatever the patient is expecting, actually that might have happened. So in this concept, the memories related to the threat expectancy would be more dominant. So what the EPT model, the exposure that we previously discussed, that is a predominant model, they do not necessarily handle these three things. They do not handle this reinstatement of fear. They not necessarily handle context specific. They not necessarily handle reinstatement of fear, which is not in their hands. So what they're proposing in the innovative learning model, this three also has to be somehow worked during the exposure therapy. And the basic aim of the innovatory learning, the word is innovatory, matlab here the sense is that the learning associated with the non-threat expectancy inhibition, it should be more dominant, like it should be upsetting these three things so that the retrieval memory or retrieval cues associated with the non-threat expectancy should upset the threat expectancy related informations. How to do that, how the exposure now will be modifying that we'll be discussing in the techniques of this. But coming to that, whatever the techniques we're going to discuss, it has a little modification from the EPT model. It's not about the major modification. You have to keep in the aim is that whatever exposure doing, this should offset these three things that we now discussed. So coming to the first technique that I shared with you, that is known as expectancy violation. At the initial part of this discussion, I asked you two scenarios. Which of the memory you are going to retain for a longer period of a time? And all you told the second one. What is the reason of that? So since a workshop, you are supposed to say something. What are the reasons behind it? I kind of gave you already the answer.
Hello. So what we expected, like we expected, oh my god, we are already sitting eating this bekar sa khana, and we will go and eat like good khana. And when we went, what the reality was not exactly what I expected and came with. And that is what, when there is a discrepancy between what I want and what I have, the that memory or that experience stayed with us for a longer period of time.
Even if the first was positive experience, it's not about positive and negative. Say for the things that you're expecting something negative to happen with you, and you got a very positive appraisal, that is going to stay for a longer. The more different the expectancies that, and that is a discrepancy of what really is happening, the more it is going to store for a longer period of a time. That is a simple thing. That is a central technique in the inhibitory learning. So our exposure has to be designed in that way. It should be creating this mismatch of expectancy. How, using only one experiment, you are trying to create 4 to 5 different types of mismatch. I am now going to explain it. In EPT model, we are focusing only one way. But here, they are given same experiment, same behavioral experiment, same exposure therapy, same session, same thing can be done in 4 5 ways to create different mismatch of experience. More the mismatches violation is there, more the learning gets stored for a longer period of time. Simple. The first is temporal prediction. What is the temporal prediction? What length of time? What length of time? So, for example, if I'm going to hold the knives, so OCD compulsion, if I'm going to hold something very sharp objects, I might harm someone. Okay, harm compulsion, harm obsession. What the patient does, he doesn't hold the knife at all. Okay. So here the question is not simply exposing to that thing, rather to ask him at what length of time you can hold the knife so that you think you are definitely going to do that act. Are you getting it? So it's a temporal predictions. This example is clear? Similarly, since it is a workshop, I want you to tell me, say for a contamination, okay, how we're going to do temporal prediction there. Anyone else? I'll give anyone. Please, we'll share it with others. Those who will say, yeah. Please give the mic. People have to, try to answer. It's a learning. It's not simply I want to speak over the session. Yeah.
So say after what length of time you think you can hold until you will have to go and wash your hands?
Okay, that is okay part. Okay, good part. Can anyone do the improvisation on that? That is also acceptable. I'll come to that.
Till what period of time you can hold so that you don't feel contaminated?
See, again, never, this is why I wanted to have discussion. Never target filling component during the exposure. Filling cannot be, you'll always feel anxiety. The moment you're targeting fillings in the exposure, you're down to fail. The filling will always be there. Rather, the better questions, that is also a valid answer yours. I'll just improvise on that. What is the field consequences? If I hold, what is going to happen? You tell me. Disease. I might have disease. Within how many minutes you will develop a disease? Simple. आपको इसको कितनी मिनट तक पकड़े रहोगे तो आपको लग रहा है कि 5 सेकंड तक डिजीज नहीं होगा लेकिन 15 सेकंड पकड़ूं तो शायद डिजीज कुछ हो जाए. Are you getting it? That is also valid. I'll come to later on what you told. See, this is not a definitive answer. It depends upon what the patient is having a field consequences. So I'm from kind of hypothetical, I'm giving the answer. But the initial assessment I told you, you have to elicit the events, patient related field consequences, third coping behaviors. So I'm using a generic term to explain that. Okay. But learning, so don't feel bad about the wrong answer. This is for the learning. Never target fillings as a field consequences. Always try to target something that is objective in nature, something that is verifiable in the nature. Never target fillings. Never. Because that can never be validated. You will be always having an anxiety. I'll come to that later on more during the functional goals. Anyways. Any one example of panic, can any tell me? Claustrophobia. using temporal prediction? It's a workshop, hence I have to ask. Yeah, please.
In panic, in case if they have a heart, so
Consequences. See, to target the fear, this temporal prediction, you need to first tell me the fear consequences.
I might have a heart attack or something.
Heartbeat is never target. Yeah, that is always be there.
Yeah.
That's what I wanted to ask you. Heart
Yeah.
attack. Yes.
So if you are there, if you continue being in a claustrophobic environment, when will you have a heart attack?
Maximum what time? Within how many minutes you'll have a heart attack? Within how many minutes you're going to heart attack?
Right.
Without not looking away, if you're staying there, how many minutes you're having it? Okay, understood? This is how the temporal prediction works. This is basically also doing the EPT model. More or less. This is not that different from EPT ILT model. But as I told, during the exposure, you need to create many such kind of questions. So many violation will be there, more expectancy violation, more chances of getting stored in a long term. What are the other ways? Intensity of expected unconditioned stimulus. Say for example, you're thinking I'm going to have a disease. Could you explain how you're going to have, what is the intensity to the disease? Can you tell me how whether your hands will turn red or what XYZ is going to happen? Try to make it more operationalize the things. If I'm going to be rejected, how severe will be the criticism in the social anxiety situations? How severe it is going to be any kind of panic situations? Intensity, how intense it will be? Can you describe that? If the gas is going to be blast, how intense that will be? Or what exactly thing is going to happen? But asking the intensity of that beforehand. All this has to be asked beforehand. Another way is frequency or occurrence. Say for example, 7 times I'm going to have in 7 different days, I'm going to toss these things. 7 different times I'm going to have the disease. Or say for example, social anxiety. If I'm going to 4 times to the faculty in a different days, every time I'm going to be criticized or only once. What is the frequency of the expected feared consequences? Is it once or is it always? Ask beforehand. Okay. Next question is that capacity to tolerate. That's what she was kind of told the answer there. What is capacity to tolerate? This is basically many people use that. What is the feared consequences in the OCD? One of the remember, it's not only something bad is going to happen. Many patients will know that I actually know that is not going to happen. But I'm not feeling satisfied. I'm not feeling relieved unless I do the compulsion. The distress component is too much. Even if they are not sure, they kind of know nothing bad is going to happen. So there we say component, they have learned that until or unless I do compulsions, my distress is not going to come down. The compulsion has to be done so that my distress will come down. Understood? This is a very critical component, very subtle component. People avoid this. Not avoid this, they do not do target in ERP. The distress itself is a few consequences. What is if I do not engage in compulsion, my distress is not going to down. So in this distress tolerance, what we're going to say that you may not do the compulsions, but whether the distress is going to be similar always, are you getting it that? The distress is going to be always the same. That is what the patient is thinking. No, my distress will keep on increasing. Forget same, it will keep on increasing until unless I do compulsion. So here, okay, how much minutes do you think? How much minute you can tolerate? How much this distress element will be there? So then you do the ERP there. Eventually what happens? The distress rises and it comes down. That is violation of the technique. But if you're targeted in this way, questioned in this way, when the post exposure, you can discuss that, actually things came down. So here what I'm trying to explain is that in one similar experiment, you are able to create this 4 and 5 different types of mismatch of expectancy. Not only focus on one mismatch, the basic concept, more the mismatch is, better is the strengthening of the memory for a longer period of a time. But again, in all the cases, everything is not possible. That being a clinician, one should be mindful. Watch this. Out of this 4 models, 4 techniques one has to use for mismatch, this should be your acumen. Say for the patient is telling, बुढ़ापे में जाके मेरे को पाप लग जाएगा और ऐसा काम. We're not going to do exposure till बुढ़ापा, right? So temporal prediction may not work there, but other 3 will work. That is what some people say in the OCD, if the consequence is too far-sighted, what I'll do? Answer is this, do in other ways also. You don't always have to stick to the temporal prediction there. Hope you understood this one. We all on same page? Okay. And go to the second technique. Deepened extinction. Okay. To any guesses what it would be deepened extinction? Anyone? Any idea? I won't waste time. I'll move on, then I'll ask later on questions. In EPT model, what we do, basically, we expose one at a time. Say for when you're picking something from the middle of hierarchy, we expose ourselves, then we only move on to the next hierarchy. Something has been decided and we take one cue at a time. Understood? Okay. In deepened extinction is nothing but combination of 2 different cues at one session. Instead of doing one cue at a time, we'll be combining the cue. But what is the principle behind that? Both of the cues should be eliciting the same feared consequences. By touching this, I'll have a disease. For dirty mouth, by touching the floor, I'll have a disease. That things can be combined. One is predictor of a disease, another is predictor of death or something else, should not be combined. Are you getting it? All the feared consequences can be combined if both of them are eliciting the same type of feared consequences. Okay? Okay. So how it can second hand, other ways also that I'll come to the latter on. Okay, anyways, that this combination can happen. 2 external cues together, you are combining 2 external cues, or 1 internal or external cues. I'll explain to that. But okay, can anyone give me example of 2 external cues other than what I said? How you can combine 2 external cues? Combination multiple cues, yeah. So combination can be internal plus external, external, any combination. But 2 different cues has to be combined that are predicting the same feared consequences. So can anyone give me example of 1 internal and 1 external cue in the OCD? How you can combine that during the exposure? You may be wrong. See, somebody gave a wrong answer. That is the reason I am able to give you the more explanation. So it's not about what's right and wrong. Please try to come off, then I'll be able. Yeah.
Two external could be like, I used to work with this client. I have to take 62 steps to my bed and then I have to jump to the right side of the bed. So if I will not take 62 steps, my boss will get mad at me. Okay. And if I will not jump to the right side of my bed, my boss will again get mad at me.
I'll do the exposure. I will do the exposure here. Good.
Yeah. So it's like, okay, let's take that first thing that you said, all that. And then we can do is like, okay, so let's try this. Taking 16, not 62, but
maybe 5 steps.
5 steps. And that not
immediately then jump to the right corner. Intention. Yeah. Good, very good. This is a 2 combination of external things. These both are predicting the same feared consequences. Now my question is, try to combine 1 internal and 1 external cue. Want to try? 1 internal and 1 external cue. Think about it in OCD. Think about it. Yeah. Internal cue counting matlab what? Could you explain?
Internally, I'm counting 1, 2, 3.
For
then the internal cue wise.
No, see, the point is that the cue should be eliciting the anxiety. So internal cue matlab anything that is predicting the anxiety. I mean, by counting, will you have anxiety? See, all
if I don't count, then I'll have anxiety. So I will
having that component.
Yes,
okay.
yes.
That is what. That is how somehow we did it, right? He told me, and 5, I'll be intentionally doing 5 times. So he counted kind of that.
Okay.
So try to think. It's very essential for OCD. That is the reason I'm taking little time on that rather moving ahead.
Probably something one of my clients had was I have to say a particular, he had a particular sentence in his mind. I have to say it 4 times before I get into the car, otherwise, my car will meet an accident.
Okay, fine. If I don't say, then car will get an accident. Okay.
Right? That was his fear. And so,
if I have to count something.
no, he would say a particular mantra. And
If I don't say that, then I'll have an accident. Okay?
Yeah.
So, what combination here can be? What is external, what is internal?
So, the mantra, internally, he would say that.
But
It's
you
a
say that
mental
it's a
compulsion.
compulsion.
Yeah.
How can there be exposure? Think about it. That's why I'm taking time here, not rushing. I'll tell. Okay, fast. See, here what will do? What will the exposure in general exposure? You tell me. First, you tell me in general what should be the exposure. Forget internal, external there. What should be the exposure here?
Getting into the car.
Getting?
Or being near the car. Probably.
Getting in the car.
Being near the car, or not just saying it once, not the 4 times that he has to.
Say for example, if that is the things he has to 3-4 times, I have to
Just
speak
4.
out the
It
mantra.
was specifically 4.
4 times. Okay. Here what you can do? Only I'll tell one mantra. Not 4 times. Okay, that is one exposure. Plus, intentionally I'll think that I'm going to have accident. Try to get it. I'm going to have accident. I'm thinking of accident. I'm going to have it. That is exposure. Think that you're going to have accident. Do not think that I'll not have an accident. I'll think I'm going to have accident, and first I'll tell once a mantra. Now I'm going to have accident. Now I'm going to have accident. Got it? It's a combination of 2 things. What example in the harm impulses? Basically people have it trapped in how to expose in the thought obsession. It's very easy. Understand that there's the concept behind it. The how to target compulsion, you'll get it. Say for, if I'm holding the sharp objects, I might harm someone. What is the feared consequences here? See, all designing the exposure should be very clear with the feared consequences. Then only you can design it very easily. Here the fear is that I'm going to harm someone, right? To prevent that, I'm going to do everything. So the exposure will be, you'll do everything to actually harm others. Say for example, I'll hold the knife, that is external cue, because avoiding holding something. Intentionally, you are exposed to the thought level. Yes, I'm going to harm. Yes, I'll think that if I thought comes of harming somebody, then I might harm really. So intentional think of harming. Intentionally think of harming for 2-3 minutes or 1 minute, then hold the knife, not together. Are you getting it? It's a combination of internal as well as an external cue. So this is how the depend extension happens. But the one principle, the most be targeting the same field consequences. Second component, any one of them has been exposed independently in the previous session. Do not start with instantly 2 sessions, 2 cues. One has been exposed beforely, then you're combining the second part. How theoretically it helps in. It's not working. Yeah. Why limited learning is being done? Use here. First is context. Okay. Yeah. Second is reinstatement of fear. Third is no. Third is context renewal, reinstatement, spontaneous recovery. Okay. Main idea is to create mismatch of expectancy. Okay. एक चीज से डर लग रहा है, 2 चीज से ज्यादा डर लगेगा, कम डर लगेगा. Simple. You are exposing one at a time, but you are now exposing 2 things. So obviously the fear will be more expected to be high. Okay. Second component, try to understand. Obviously I'm assuming you have already learned EPT, hence I'm discussing that. Say for somebody is exposed to the emotional, any cue. In the habituation, the start anxiety went high, then it came coming down. When it is coming down, This is how again, you are exposed to one cue at that point of the time, then the anxiety is reducing. When it has been reducing, again insert a second cue. You have not added than the previously, now add the second cue. When you add the second cue, what will happen? Anxiety might go up again. So this is known as reinstallment of fear, right? That's I told something actually happens to the patient that he was fearing. So that practice also has to be done. Whenever there is a and we want them to practice this reinstallment concept also. Intentionally introduce another thing that patient is fearing. So by this way, it also helps the reinstallment of fear that happens in the normal life. By getting it, so the different ways of doing this are thing. Hope you get a hold of it. Yeah. Obviously, to concept, it increases the mismatch of expectancy. एक चीज से डर लग रहा, दो चीज आ गया. But outcome the same ही होना है, more or less. And second, it also helps reinstallment of fear. Now, let's come to the third technique, which is known as variability in the context. This is quite easy, and this is few people might have done when I was doing it even initial part of my career. I did not know this is intuitive learning, but somehow I was doing it. So, but since they have emphasized, the context ties in the specific learning ties in the specific context. So here it is encouraged that they should be doing the exposure in a different context. Not only say, for example, tied to one concept or not the one kind of stimulus. You are exposing the knife, change the stimulus. Maybe use another sharp objects, anything, maybe fork at the same time, maybe any other sharp objects. Vary the context as much as possible and vary the environment as much as possible. Not only get tied to one thing. Then what you can do, say for example, contamination patient. Can anyone tell me the contamination example? I should not say everything. The learning also has to happen. Any example of this variety in context in the contamination patients? Yeah. Okay. Okay. Okay, these are the different cues. Of the same cue, change the context. That's what I'm trying to ask you. Multiplex, go to the nearby multiplex. Go to the washroom and intentionally use in the washroom or intentionally use the hands. That's what I'm trying to change as context as possible. What we did in the first study in this ILT in our country, that is that we used the concept of that, maybe surprise cards. What the co-therapist or any family member, what they'll be given 3-4 cards. By we are writing the cues, okay? For the contamination, these are different cues. He has been exposed during the therapy one session or in the home also one more session. During the further session, the co-therapist has to open up the card and tell me the cue what exactly he is to do in what environment. Maybe you'll open up, go to the nearby washroom and do that. Go to the nearby cafeteria and do that. Here thing is, why is a surprise card? Again, sometimes when we expose to the client beforehand, this is going to be session, that is okay, that is should be done in the initial part of the life, initial part of the session. But later on, surprise element should be there. You should not be always cognitively expecting. Okay, this is cognitive preparation is also sometimes also a coping behavior in a long term. For everything has to prepare everything. No, in the real life, nothing really happens. Something instantly it happens. A reinstallment of fear. So during the latter part of the session, you won't be given much time to think about these events. Give a surprise card. Okay, now you have to do this. There is no point of giving that preparation element in the cognitive mind. So that is also different context. Also, it is trying to combination the reinstallment of fear. Okay. Now this is the variable in the order of cues. When I ask my students from the name answer, what is the difference between ILT and EPT model? They mostly tell this technique. This is not actually the only difference. This is one of the difference, and the point here I'm trying to make is that whenever somebody is asking you, you should not tell this is the only difference because it catches the attention very quickly. Jo dikhta hai, wo bikhta hai is kind of that. But this is zyada dikhta hai in ILT. But this is not that main component. But still, I'll tell you. What we said that in the EPT model, it has to be graduated in nature, right? We'll start from the medium, then we'll move high. But here, what they're telling, we have to do a variety in the order. Start with the middle. for the buy-in approach. You have to start with the middle approach only. Then actually randomize the order. It may not go in that graduated fashion. The next session, the next queue may be the least feared or maybe the highest feared. Are you able to get it? Earlier it was to gadget, but here the randomize the order, but to begin with the middle always. What is the rationale behind is that in the life nothing happens in a hierarchical order. कुछ भी हो सकता है. So during the therapy, you also be exposed to that randomness of the order, not only the mental preparation. And also this is helps with the reinstatement of fear. कभी ऊपर कभी नीचे, so that it is not following a predictable order. So hence that is also helpful in that way. But I recommend only to be done this when the patient and you are seeing that the patient is learning. Maybe after 3-4 sessions of exposure, do that. Do not start it from the initial part. I'm doing individual learning, so I didn't do this. Sorry, I did it very less. But I focused mostly other techniques. But yes, also can be done. Reminder cues. Can anyone tell me from the last 2-3 months where you have visited? I mean, it's a personal question, but the point I'm trying to come, I'll tell you. Where you have visited? कहाँ घूमने गए हो यार? कहीं तो गए होगे. Life ऐसी boring थोड़ी हो गई है, नहीं गया. Anyone? Mentally think about that. Okay, no need to tell me. You purchase something from that. कुछ खरीदा होगा? क्या खरीदा? Okay. चलो कोई नहीं. अपने पहले relationship के बारे में सोचो. Given something, gifts, anything like that. What is the purpose of any kind of gifts or whatever? What is that? You remind, is a memento. Memento will be getting right now. Maybe hopefully, okay, fine. So you might remember, okay, oh, yaad rahega, huh? That is what, this is, reminder cues is all about that. Similarly, think about our situation. Combined to concept. We all know what to do in a specific situation. हमको सबको मालूम है यार, कोई इतना बेवकूफ नहीं है. But during the heat of the moment, we forget everything. We go to our learned behaviors. Then you think, यार मुझे ऐसे बोलना नहीं चाहिए, उसको ऐसे जवाब देना नहीं चाहिए. बाद में पछतावा होता है कि नहीं? होता तो सबको होगा, और सभी लोग वही मिस्टेक करते हैं. Is if like I just went out of impulses, I forget what to do at the heat of the moment. During the heat of the moment, people forgets that. Same thing happens if it is predicament to all of our life. Same it happens to the patients. They have learned during the exposure they are not supposed to do the response prevention. I mean the contamination or compulsion or safety behavior, but they end up doing that instantly. Then later on repent for that. Hence, there has to be reminder cue. Reminder cue that always remind them you are not supposed to do that. So what is that? It may be a different style quotient of maybe a different, people are wearing bangles. Yeah, she's kind of wearing 2-3 things. Maybe another different color of something in the hand to remind that this is what I have learned during the therapy. This contamination is not, the feared consequence is not going to happen. I'm not supposed to do the compulsion. It's just to remind him, this is what I learned in the previous sessions. Okay? Or it may be a different kind of ribbon, different kind of anything that is different from what the patient is wearing, so that it's always visible and it's personal to the thing. Nobody should make out of that anything. It's just to remind him, aapko aisa nahi karna. During the heat of moment, every time is to forget it. So this is a very simple. This has nothing to do with exposure designing. Yeah. I was going to come it. I was going to come to it. But let me first explain. Maybe different chudi, different bangle to symbolize that what I have learned. Okay. Say for example, there are 5-6 contamination cues. Okay. You have learned in the 2 things. Let's use a reminder cue. And the point that you're trying to is not to be used in the slide during the early part. Should not be done in the early part. Reason is that itself will act as a safety behavior. If it's not done, I'll feel very uncomfortable with it. So that's what, and not to be used in the early part. During the latter part of the session, you are planning the relapse prevention, not during the early part. 7-8 सेशन खत्म हो गया, मैं बस ये कुछ लगा के आ रहा हूँ कि मैंने ये सीखा हुआ है. with OCD, any kind of patients, it can be done. Again, second component, change the reminder cue after every 1 week or 2 weeks if it is possible. Say for example, मैंने एक लिखा था कि मुझे when I started to learn XYZ, I'm not going to say that. I am supposed to do this and not to behave in that way. I wear a different kind of kada. After एक हफ्ते के लिए ठीक था, उसके बाद kada kada ही जैसा रहा. It became only style question. So it loses its value. So better to change the reminder cue in every 1 or 2 weeks. It's very simple, understandable. Hope. So this is all about ILT. Okay, I won't focus about the publication. I have very less time. Last 5 minutes I'll take about it. Even I'll skip to this part. This was my favorite part, conceptualization through metaphor. You can go to my papers and learn about that. I don't have time for that. Okay. One key component I'll tell you. With that I'll going to end about it. We have 10 minutes, right? Because we started late. Time, na? Fine. Okay. Koi nahi. Functional goals I'm talking about. Oh, sorry. I should not. Before me telling about that thing, be open to it. What goals of therapy you have in your mind when you're starting exposure therapy? What you communicate to the patient? What are the goals? What are the goals? Hello? Yeah. What are the goals? To lessen the safety behavior. Good. Okay. Any other goals? When the goals you communicate to the patient. Think about it. गलत हो गया यार. Don't worry about that. Yeah, please. Distress management. I will come to it. So distress management was decreasing the what? Symptoms. That's what distress, decrease the anxiety. Okay, more or less. Any other goal than decreasing the anxiety? Any other different answers? No, that is a goal. You are picking the goal to experience anxiety. Exposure, no. That is the mechanically it will happen, but the goal of success part of the therapy. That's what I'm trying to say. That is operationally, obviously, in the exposure, anxiety will be high, definitely. But the goal of treatment, that's what I'm trying to say. See, as a, I'll tell you, think about a physical. Mostly we focus decreasing anxiety, which is very actually not a right thing to do. Let's talk about he's a physician, he'll better able to connect it. We have a, say for example, if a physical illness, headache हो रहा है. Simple aim क्या होगा वहां पे जब ट्रीटमेंट जाएंगे? हेडेक खत्म हो जाए ना. Think about it. There's nothing harm in that. That's practical thing. सर दर्द हो रहा है, बुखार हो रहा है. Zero has to be the only goal there. Then only we'll say treatment is successful. Similarly, whenever there is anxiety, whenever any kind of neurotic illness, for them as the patient, ये जब zero anxiety हो जाएगा तभी जाके successful होगा. और आपने उसको गोल भी डाल दिया, तो everything is going to think about whether my anxiety has come down or not. Anxiety will be forever there. Anxiety is not a bad thing, right? It is going. Even if right now I may not be having anxiety, बहुत बार बोल चुका हूँ ये भाषण, तो शायद नहीं हुआ होगा. Maybe instead of you, my professors, whether I could have same anxiety. Okay. So thing is that anxiety is not a problem there. But his goal is always that to make it zero anxiety. And our goal of therapy is also that. That will complicate the things. Anxiety is not a bad thing to have it. Rather, have it the goal, but mix with functional goals. See, every one of our anxiety might be having, but if we are able to do our functional things, the last two criteria of any DSM, ये तो होता है ना? That should be functional, impairment, socio-occupational functioning. तभी जाके हम उसको disorder बोलेंगे. नहीं तो नहीं, सीधी बात है. So have this functional goals in the life. You do anxiety. What things actually is not doing? Try to get it. He is now avoiding presentation in SAD. He is avoiding walking in front of a group. Small things. He is avoiding looking into the eye to eye to the opposite sex, or having a small interaction. These are the functional goals. Always target functional goals. Also have symptomatic goals. That's not, I'm denying it. But initial part of the therapy, focus more on the functional goals. Okay, why I'll come to that later on. Second component, patient have a cognitive distortion in anxiety disorder known as maximization minimization. They are going to minimize their success like anything, maximize the failure like anything. एक तो obviously, as a layman, if I did not have studied clinical psychology, I would have expectation zero anxiety. ऊपर से anxiety का personality maximization minimization. So they emphasize little bit of anxiety here and there. Oh, still have illness. Their confidence is down. Third component, एक होता है, there's a little technical concept behind is that is known as integrated values goals. What I am trying to say is that मैं ये काम करूंगा, मेरी एंजाइटी खत्म हो जाएगा, कम होगा. दूसरा पहलू है कि मगर ये भी काम करूंगा, मुझे मेरा कैरियर अच्छा बनेगा, मुझे पैसा फ्यूचर में ज्यादा मिलेगा, से फॉर एग्जांपल, और चीजें ज्यादा मिलेगा. तो किसमें ज्यादा मोटिवेशन है? एक काम में सिर्फ एक ही गोल है, ये टैबलेट खाऊंगा हेडेक खत्म हो जाएगा, लेकिन ये टैबलेट खाते हेडेक तो खत्म होगा ही होगा, पैसे भी मिलेंगे, कैरियर भी अच्छा होगा, ये सारी चीजें अच्छा होगा. The more goals we have in our life for doing one particular thing, more will be the motivation. Functional goals you are targeting, that is more integrated in concept, only not focus on the symptomatic, rather how doing this exposure is going to enhance the functional goals, and those goals are central component of your future and present life also. That has to be communicated at every जब consolidation होता है ना, exposure करने के बाद हम करते हैं, we need to explain this, how this act of exposure has helped you to go towards your functional goals. ये possible कैसे है? जब आप थेरेपी करने से पहले आपने functional goals रखा हुआ है. At the end it is not good. Hence you are beginning the therapy sessions, have functional goals in your module. Say for, I'll tell you, see, everyone having is a goal in their life. We all have goals, we make goals, but we fail to that and do not attain that. It's something different. But we do have goals in our life. But when we see that we are realizing our goals, we are achieving our goals, would not have motivation be high? Very simple. Similarly, in your goals of your social anxiety, say for example, my goals of therapy session, to that, you will be now attending more public sessions. I'll be walking more in front of the crowd. I'll be eating in front of the public, not only taking it away. For what will the function goals of OCD? Tell me. Tell me, what are the function? Social anxiety के 3-4 बोल गया. Goals of OCD. Tell me functional goals of OCD. Excellent. Decreasing time in doing something. Earlier I was taking 1 hour in the washroom. Now I'm going to take 15 minutes. That is a goal. Anxiety कम, ज़्यादा मैं इतना focus नहीं है वहाँ. Other, I was checking 15-20 times. I should be checking 4-5 times. That is frequency of time. That is a goal. Basically, have it. Okay. So, socho. These are the goals. Okay. Now, before me explaining something, I want to ask you one more component that will connect more. What is one of the largest? Okay, tell me the predictors of treatment success during the therapy. Motivation, fine. What else? Social support, family, fine. Insight, ठीक है. This client person, okay, good. Remember, one largest predictor, motivation, second is component is known as early treatment success. अपने लाइफ के बारे में सोचो यार, भाड़ में जाए treatment. When you have something success in your life, you won't feel more motivated. Very simple, right? Same thing happens with the patient. Now, why I'm connecting, now I'll connect everything together what I discussed. I made goals, functional goals in my treatment. And remember the point, motivation, early treatment success. Early treatment success always increases the motivation. Hence chances of higher adherence, hence chances of high treatment outcomes. How I'm going to connect it. Exposure में क्या करोगे आप? Hence, during the exposure therapy, you are starting the first session. In the first session, my goals will be, I am making efforts in going to far away places. Agoraphobia. Here the emphasis on the efforts. I am making efforts in increasing time spent in cardio exercises, panic. I am making efforts in interacting with seniors. The word is simply the effort. Effort of what? things that he has been avoiding in the past. Try to understand. समझो अपने आप ही होगा. This is a self-monitoring checklist. I mean, there is no checklist for it. So whatever the things that patient is avoiding, your first session, I mean first week of your exposure session, is to how he should be increasing effort to doing those things. And all those item has to be connected, rated on a scale of 0 to 10 out at the end of the 1 week. ठीक है? मेरा पहला effort है, goal है, I am increasing my effort. When I'm doing the exposure, obviously he's going to do more effort. Are you getting it? It just is nothing like a catching them being good. The moment they're having this increase in the effort, and when they're rating on a scale of 0 to 10, obviously 4, 5, 6, 7 score ही आएगा. And that will give enough motivation. Then you can say, not only effort, increasing in those activities. I'm increasing my behavior in going towards seniors, taking lesser time, that all you told, the frequency on a scale of 0 to 10, he's going to rate himself. इसमें anxiety कहीं भी नहीं है. Are you getting it? When you're trying to do this, he's going to rate himself higher and he's feeling more good. Okay, this is the goals. I'm really now progressing. Only 0 हो रहा है. आपको भी अच्छा लगेगा therapy में यार. It's not only about the client. It's also you being as a therapist to like it. Oh, really, this is things now improving. And that is all. Anxiety will be there always. फिर धीरे धीरे maybe third week onwards, fourth week onwards, try to distress level what's he told. Try to again similarly rate on the symptomatic goals. The point I'm trying to make is that not only emphasize symptomatic goals, have both goals, but initial part of the therapy session have more functional goals. And that will make a more meaning to the patient's, life, as well as if you see we all have anxiety at different place, but if the functionality is improved, you'll, as a therapist, feel good about it, probably learn more money, and probably the patient will be more happy and his motivation will be more high. Getting it? So this is the learning. If annuity learning का थोड़ा time लग सकता है, but this one simple concept you have in your mind, I think my workshop will be very happy about it. Have functional goals, and how to do functional goals? Self-monitoring checklist. Self-monitoring checklist का मतलब क्या है? Simple. Note what are the avoidance in the patient's life. What are the functional limitation in the patient's life? Convert that to this kind of format. I'm making efforts. First week efforts. उसके बाद second week onwards, every week the goal has to be changed. I'm increasing in now my attempts, not only efforts. पहले effort ही था. शायद कर नहीं रहा हूँ, इसलिए हमने efforts रखा है जानबूझ के कि हाँ अपने आप को थोड़ा ज्यादा रेट दे. Second week onwards, increasing my activities. And all he has to rate, self-monitoring checklist 0 to 10. Okay? And all this concept, I tried to came up with merging the concepts of OP psychology, where goal monitoring, not only goal formulation has to be important, rather goal monitoring is important. And yet the monitoring, why only by the therapist and family member? Why not by me as an individual? I'll be the most honest to my rating. And that is how good about it. Hence, in this way, obviously therapist monitoring will be there. And this way, he's also monitoring himself. More multi-component of monitoring will be there, more it increases the motivation, more is the adherence. So that's all. I had other topics, but I'll skip to it. Any questions? No questions? Okay, and I've suited up 10 minutes more, but we started late. Okay, thank you.
Anyone?
I'm okay. I can tell 1 hour. It's not an up to. I can. Not an issue. No, I'm okay. But okay, it should not be bonded. I'll continue. I want to discuss first 10 minutes, then wait. No, you have questions, then I'll take up the questions. Up to you. I'm leaving on to you. Okay? Okay. Okay, fine. Okay. thing is that, remember, now one of the important component what we thought of, not we, is in research is that uh, the the major concern of to start a therapy is having a good conceptualization. We need to communicate the conceptualization to the patient in such a way that he should understand the scientific rationale. If he's not understanding the scientific rationale, the exposure will be like flooding. Jabardasti karwa rahe hain. So he need to connect that the concept behind that. Why should I do that? Hence, one of the problem with the adherence of the exposure sessions, probably the conceptualization has not happened in great way. That's not the only thing. If you have done a great way, they might not do also. But poor conceptualization of the scientific rationale is a kind of a problem. अब इससे बोलने से पहले और एक छोटा एग्जांपल आपसे पूछना चाहता हूँ. Say for example, you went to market, you get 1 kg of mangoes, fine. But you went to एक पेड़ पे गए, अपने मेहनत से आम तोड़ के लाए, which will be more satisfying. Probably more. खट्टा भी हो लेकिन ज्यादा यादगार वही होगा शायद. Okay? Same concept, have this in our mind, I'll come to that. So hence I do the conceptualization in a form with a metaphor so that the main idea is not that I should tell everything to the patient. I'll give him in the framework. He should be able to come with his own conceptualization. So that this is known as identification of the value. Self-determination theory concept, how to increase the autonomy of the act. If I understand the value of the therapy and from my own, it's not what Virat Kohli does, what I can do and what I can think about it being a cricketer. That's what is more meaningful. So how we do a conceptualization, the simple act here is that try to give a structure that he should be filling it up. This is how I do a conceptualization. I'll use it for metaphor. What I do with the patient, I say him that, imagine that, this is the way I started. Imagine that I'm your younger brother, okay, to the patients. And this is my living room where I'm sitting right now. That we do, this is our old living room probably. What one fine day happened is that while I was going to the corner of the room, I reached to the corner of the room. I had a terrible itching all over my body. It was that terrible that I had to apply ointments, I have to do everything to subside it down. From that day onwards, I developed a fear. If I go to the corner of the room, itching will happen. Understood? If I reach to the corner, itching is gonna happen. Next day onwards, I started going to the corner. When I started to go to the corner, anxiety came high. You know, फिर बुरा लगा. दूसरी बात ये कि फिर itching शुरू हो जाएगा. That was not a comfortable feeling, distress feeling. What I did is that I won't go. Simple. I decided I won't. The moment I decided that I'll avoid, I won't go, the anxiety came down. Earlier it was high, later on it came down. So that was success for me. But that was my own room. Every day cannot do that. कभी ना कभी तो जाना ही पड़ेगा. Say for example, something was there in the corner of the room. It is required. Now what I'll do? Ask my younger brothers and sisters, you go and go get the things from there. The siblings brought the things towards me. Again, the anxiety came down. So these are two coping mechanisms I used: avoidance, help from the siblings. One fine day, no family member was there. Still, I was looking something from the corner. What I did, I used a stick. Get the things towards my corner. I got the things. Again, the anxiety came down. So these are three coping mechanisms I use: avoidance, help from the siblings, or using a stick. This is, I mean, then the questioning starts to the patient. I mean, I do not say him everything. Then I ask him, by using these three things, what benefit is getting there? Yeah, he's able to do the things. Now, next question. By doing these three things, whether the initial pairing that developed in the mind, if I go to the corner, itching is gonna happen. Whether that decreased, the pairing decreased, or it stayed there. Almost 99%. Say, no, it's already there. Probably it increases more and more. Now I ask my patient, you being an elder brother or sister, what advice you wanna give to your younger brother and sister so that the pairing will decrease? What advice are you giving to give them? You're a psychologist, I should not. I mean, I asked to layman person. Eventually, everyone said, no, he has to go once again. To listen the statement that, he has to go once to the corner, I kind of narrated everything in the story. Just telling exposure is the answer. But then I ask him, okay, fine, that is a perfect answer you gave me. That is the real answer. But in different way they might tell it. But that's what the main essence is, that they tell that no, one has to go once again. Then I ask him, say for example, after 6 months, somebody went to the corner. Would not be there any anxiety? Yeah, definitely there will be anxiety. But what is important to know? Anxiety is there or not, or itching is going to happen or not. But if I go, definitely there will be anxiety. But I need to go and stay there to notice that itching is going to happen or not. Well, first day I went there, I did see not much itching happen. Second day I went, there will be lesser anxiety, but there will be anxiety. But might be lesser from the first day. Second, but if I go with the mindset I'm going to know whether itching is happening or not what anxiety is happening or not. With that mindset, I'm going. Maybe 6-7 times I go, then I'll develop the pairing. Okay, there is actual itching is not happening. Probably you'll have a lesser anxiety for there onwards. But you'll have anxiety when he goes. Then he might do what kind of things, Okay, yes, that going in the corner is the right way. What I'll do, I'll go very fast and come back, or I'll start to do certain kind of mantra in the mind. We call mantra in the mind. Okay, whenever it's not having an itching, all the credit goes to taking that mantra, going faster. So that is known as safety behavior. Sometimes you expose, but with the safety behavior, and all the credit goes to the safety behavior if the fear consequence doesn't happen. So with this kind of an example, then I tell him, okay, as per your advice, our brother went for there for 7 days. Out of 6 days, he did not have any itching. Out of the 6 days, he did not have itching. 1 day he had a itching. What he should believe more, 6 day experience or 1 day experience? He'll eventually know 6 day experience. Why should he believe 1 day experience? With this kind of an example, actually gave him the entire conceptualization. Then I come to the clinical translation. I give this certain kind of example. They have to answer all these questions. Then I connect to the clinical translation of this problem. This is of your event, fear cues, and this is of your consequences. And this is how your coping behavior you have to do. By utilizing the coping behavior, the pairing gets more solidified. So what I'm fearing, whether I'll have itching or not, that is actually common experience. That is what Rachman model says, that fear consequences happens in everyone's mind. It's a universal experience. But it is not the anxiety that is a troubling. It is the coping behavior what determines how the pathological anxiety converts to one of the maintaining factor is. It's about the maintaining factor. This is the coping behavior. You are using this certain coping behavior, then you have got to a conclusion. Unless you do this coping behaviors, this is going to happen. Now you yourself has answered everything, that one has to go to the corner. So I am only utilizing your answer to recover you, but in a stepwise manner. So this is, instead of me telling him everything, I gave him a framework, then I connected his things so that probably then the concept will need to happen more. So work on the conceptualization. Another way, this one way is of using a metaphor, rely you speaking everything to them, let them answer to your questions that you want to hear them. Secondly, ask them what their summarization of it. Ask them what they have understood. Unless you spend time on conceptualization, do not rush to the trick. Conceptualization need to happen. Otherwise, take one more session to concentrate. That is fine without rushing to the things. Another way simple you can do is that after telling conceptualization of one patient, now the chat GPT is there. You can make a similar case formulation. Ask him, can you do the conceptualization of this patient? How he is going to help? So spend certain time on conceptualization. Otherwise, you should not be like, हाँ वो तो बोल रहे हैं exposure सही answer है. उससे निकलवाओ कि exposure ही सही answer है. Then you will try to connect him more better. Are you getting it? There are a lot of example, like भूत वाला example है. It will take more time. It will take time. You just can simply go to Google Scholar. One article in Asian Journal of Psychiatry is there. Is maximizing specific non-specific factor. 3-4 examples I have narrated there. Small children's के लिए, थोड़ा adult के लिए examples और छोटे बच्चों के लिए मैंने लिखा था. The idea here is that use a metaphor. Use a metaphor. Do not explain everything. And secondly, in all these things, I do not use ever the word distortion belief, automatic thoughts. See, the more you are trying to be academic in nature, it's understandable, right? We read 2 years of MPhil to get the knowledge. So हमें भी बोलना ऐसा है. Tell all those things, but use less academic word as much as possible. In this example, I do not use any of these things. I present it as layman as possible. So think about, how patient will connect it. For him, that is not you as a learned individual is more important. Rather, patient as his own way of connecting the thing is more important. Or simply ask conceptualization. After you narrate something, ask them you to narrate to you. Whatever they understood in their own terms. Thirdly, give another case to them कि मैंने तो कैसे वो केस मैंने आपके बारे में बता दिया, दूसरे बंदा भी उसका सिमिलर प्रॉब्लम है, आप बताओ उसमें हम क्या क्या कैसे कर सकते. This is the third also. This is all I'm using is not nothing is from my mind. This is known as cognitive learning strategies done for some other things, So how the transfer of learning takes place. You also give him certain other cases that he should conceptualize it and he should tell to you as a homework exercise. May not immediately right now. Give in the homework session. आप उसका conceptualization लिख के लेके आओ. Then you will be thinking of different examples. कोई भी आपने टेक्स्ट बुक में एग्जाम्पल पढ़ा आपने. If I ask you what is classical context, time कुत्ता बिल्ली explained everyone will tell me. But until unless you are coming with a different example, then your concentration will be more better. Hence, this is based on that technique. You ask the patient to come with another example. You give him the example. He has to tell the concept of that particular patient. The moment he is telling the concept of the patient, the learning has happened. That is a transfer of learning. This is known as cognitive learning strategies, retrieval practices. You can Google it, it will get about a lot of things. So that is more or less. Yeah. Any questions? I will be happy to take it. Yes, ma'am. Somebody is having. She's having. Yeah. Pretty good.
Hi, am I audible?
Yeah.
Yeah, congratulations on your presentation. So, my question is basically, you said two things in your presentation. One was कि एक तो पेशेंट से निकलवाना कि आप अगर खुद उस सिचुएशन में हो तो कैसे कोप करोगे. ये तो हो गया उसे गाइड करना एक तरह से ताकि वो अपने आंसर्स खुद ही दे सके. एक जो चीज आपने बोली वो ये बोली कि पेशेंट से खुद पूछो कि अगर उसके सिबलिंग्स उस सिचुएशन में होते तो वो उनको क्या बोलते. हाउ मच पॉसिबिलिटी इज देयर कि वो पेशेंट यही बोलता कि कभी ना कभी उस सिचुएशन में जाके तुमको खुद से कोप करना ही पड़ेगा. इसके चांसेस कितने. बिकॉज माय पॉइंट इज कि यूजुअली ऐसे सिचुएशंस में इनसाइट इज देयर बट हम ये कह सकते हैं कि इस तरह का आंसर उनसे निकलना इसकी प्रोबेबिलिटी बहुत कम है. टू बी वेरी ऑनेस्ट. So I would really like you to throw some light on that. That would be a great.
I have conducted probably this session with a lot of, not clinical people, different session IITs and NIT whatever. 99% पेशेंट की बात तो नहीं बोल रहा हूँ. 99%, 99.99% सभी बोलते हैं हाँ दोबारा जाना पड़ेगा. सिंपल चीज है, मेरा पैरिंग डेवलप हो गया, जाके मेरे को वहां पे खुजली होगा, कैसे काम होगा. हर को नहीं, मुझे जाना ही पड़ेगा. कमिंग टू द पेशेंट, शायद गिनती तो मैंने नहीं किया, 200 300 400 पेशेंट तो देखा ही होगा. लगभग 95 or 98 99% they have told no. They'll tell okay sir, I'll tell you their versions and giving the conceptual answer. सर पहले तो मैं उनको साथ लेके जाऊं, हाँ नहीं तो खुद भेजो, मैं दूर के खड़ा होगा, उनको बोला तो जाके आ. But all the gist is that they'll be emphasizing one has to go to the corner, and this happens with across everyone I have. Bearing maybe very few patients, 5-6 out of 4 and 500, they may not answer. That is what I was telling to him. उस केस में we only rely on the habituation process.
तो बेसिकली आपके कहने का ये मतलब है कि ये जो आंसर हम एक्सपेक्ट कर रहे हैं that could probably come after a couple of sessions rather than that.
Simple. Spend this, that's what I'm trying to say.
Okay.
Why you underestimating the patient? Ask the concept. Give this a metaphor and ask them. I'll bet you take my email ID, you do it 2-3 patients. I'll bet you they'll tell you the answer.
Because this has not happened with me personally.
Have you given this kind of a conceptualization?
I have actually. So this hasn't happened at all. ये होता है, but probably after a couple of sessions.
2-3 more examples. Go to the paper. Until unless the point is that until unless you're hearing the answer exposed. See, The whole idea is that the concept of self-determination theory, identified regulation. I should be understanding the value of the activity rather than somebody telling me. Spend time. It didn't happen with one example. प्यार से और दो तीन example बनाओ. Do not rush that, that should be, you should be telling that. I mean, try your best. Try your best. मैं बोल रहा हूँ. I mean, literally, मैं तो बहुत humble होके बोल रहा हूँ. 400-500 उससे भी ज़्यादा देखा होगा. Bearing 4-5 patients. Even some patient I thought about ये psychotic बोल नहीं पाएगा वो मेरी, but they also told. But in certain very less, 1% less than 1%, they might not have told these things. Everyone has narrated across not only patient, across different students population. I'm mostly working the community population right now, not students having the real clinical problem, but with the prodromal anxiety also. Everyone narrated, no, that is the answer. That is, one has to go to the corner. Eventually, everyone tells that. You start doing that in the proper way. Just right now, Google, I tell you the paper name. It is in this case was properly narrated in the Indian Journal of Psychiatry. Is a case report. When I first came with that, later on I used it in all of my papers. Indian Journal of 4-session best exposure, something like that. 4-session best exposure करके कुछ होगा in Indian Journal of Psychiatry. So you'll get that proper narration. Use that. I bet you mostly they will do. You were asking something. Yeah. Otherwise, that's why rely. Go to the ask them your conceptualization. You don't answer to them immediately. Inhibit little bit. Yeah.
Good morning, sir. Thank you for your presentation. My question is that you spoke about functional monitoring in the beginning,
Okay.
right? Functional activation, and for that you said we should be monitoring,
Self-monitoring checklist.
self-monitoring. So I think a lot of times, how do we deal with it when the patients don't maintain this monitoring record?
So how?
When this monitoring record is not maintained by the patients. So do you do this in the session and like how do you deal with
Obviously,
this?
as I told you, 3 components in multi-source feedback मैंने वो दिया था. Multi-source feedback में obviously first the patient has to rate it. He is not doing, obviously you will begin your session with the revision of the homework session, right? That is the module of CBT. The first beginning will be the revision of the homework session. In the homework session, simple, इसमें ज़्यादा time लगेगा, only 2-3 minutes maybe. Okay, our exposure was to that, our session was to go to this XYZ exposure event. On a scale of 0 to 10, how much effort you have done? How much increase of activities you have done? It will take 1-2 minutes. You will do from yourself and beginning you need to do. But the point here is that I'm emphasizing self-monitoring more than the therapist. हम हमेशा दूसरों के भरोसे क्यों बैठे रहे? If patient is doing that, the all idea is that he'll be motivated. Here the thing is that if I'm going to rate that, how I've learned from my skill, if I'm rating that now 5, 6, 7, I'll be more motivated to learn do the things in the next time. So better if the patient does. If it's not doing, obviously your every session will start with revision of the homework session. There you can do these things. So there's 2 components you're adding. Yeah. This is having also.
So again, going back to earlier part of your presentation, when you were talking about the expectancy discrepancy, if the client does get overwhelmed, if I'm saying, okay, let's assume that this is what's going to happen. If that is creating more anxiety, how are we supposed to handle it? Again, do we go back to explaining that in any case it's an irrational thought, or how to handle it at that?
Again, to technically answer, even the expectancy valuation technique, when you do innovative learning wala concept, we're not supposed to give you more explanation. The more explanation is going to happen, the anxiety will actually decrease there. So we are decreasing the opportunity of mismatch there, right? So what I'll say, without you explaining, giving that, decrease your cue there. To not give that cue that is having heightened anxiety. I'll give you an example. Social anxiety, हमने उनको दिया था कि, for example, change the item that simple the answer, not you explaining the things. Item was that you need to go to the faculty and to speak something. So what is the main fear of the social anxiety? Each and everyone is going to observe me in a scanner-like manner. Like I am saying right now, obviously everyone is observing. But their expectation, people to observe how my side locks are there, how my betel is fogged, how my shirt creases are there. और सभी मुझे ही देखेंगे सबसे पहले, बाद में criticism आता है. If they are going to see me, then they will, notice all this mistake, then they'll reject me, humiliate me like that. तो वहां पे instead of directly targeting the third fear consequences, target simple चीजें मैं अपने बोलता हूँ. मेट्रो में जा रहे हो ना, फोन देख लो, जानबूझ के ऐसे देखो कौन आपको काट रहा है. I mean, and how many people are actually looking towards you? Out of 100, how many really people are looking towards you? 4-5 people? Is that 4-5 is not looking to anyone, only to you? Are you the lone kangaroo in the Australia there, or is it not a universal experience, only exclusive to you? Then you'll, okay, this is actually common thing. So instead of you explaining the things, better decrease the level of you there, so that you will be able to start with it. Not necessarily every time you have to start with a moderate wala hierarchy. So you explaining the things. See, if you're not following innovative learning, maybe for the one session, before the therapist they will do about it. Mostly it happens. You can then see, आपको ऐसा लग रहा है, करके तो देखो, यही तो हम सिखा रहे हैं आपको. कॉन्सेप्चुअलिजेशन मैंने क्या बताया था? The point here is not targeting anxiety there. Point here is that feared consequence is going to come true or not. Right? Anxiety will happen. But you do it, I am here, let's see what is going to happen. वही तो हम सीखने के लिए जा रहे हैं.
Right. So initially to start with a lower Q and later, like you said, we can mix and match.
At all doing it. He's not actually doing it. Then better do spend little bit time on conceptualization, decrease the Q, but do not reassure him more that nothing is going to happen. That word you should avoid it. आप करके तो जानिए. Reassurance is always a safety behavior. See, again, it's nothing one answer. Maybe in one session you did give a reassurance, but next do not always try to give that. Yeah.
Thank you, sir.
Because many times the patient, as you said, I also know the patient are aware. now मुझे feel करना है, लेकिन उनकी ये problem हो रही है.
डिस्ट्रेस हो रहा है ना. दैट्स व्हाट नथिंग. मैं वही मैं बात सो टाइम नहीं मिला उसको ज्यादा एम्फेसिस नहीं किया. सी, मोस्टली वी टारगेट द एक्सप्लिसिट feared consequences, but before that something else is always there. The distress itself. It is the distress. They think that unless I do my compulsion, my distress is not going to come down. हम उनको सिखा रहे हैं डिस्ट्रेस. आपको लग रहा है ये घंटे भर रहेगा. दैट्स व्हाट. चलो करके देखते हैं डिस्ट्रेस कितना देर के लिए उतना रहता है. उनका मन में क्या है, ये डिस्ट्रेस वैसा ही रहेगा, इट वोंट कम डाउन. Convert that as also feared consequences. That's what exactly I'm trying to say. Not only something bad is going to happen. Second feared consequences जो हर कोई अवॉइड करता है, write in the statement, unless I do compulsions, my distress is not going to come down. So when you started the exposure, SUD level कर रहे हो, starting में क्या हुआ, maybe 70. After 5 minutes, 80. After 5 minutes, 90. After 5 minutes, 20. After 5 minutes, it will start coming down eventually. So धीरे धीरे जैसे I didn't explain that EPT model, graduated repeated prolong. What is the prolonged feature? Unless the initial anxiety comes to 50% of the thing, we need to do the exposure till that point of the time. Starting 70 हुआ था, जब तक 35 तक नहीं आता SUD level में, exposure होना चाहिए. When the exposure really came down, anxiety came down without doing the compulsions, the first feared consequences was negated. पहले क्या था आपके मन में कि unless I do compulsions, my distress is not going to come down. Now let's see within how many minutes your distress came down, and that time did not do any compulsions. So target the distress itself as a feared consequences. Are you getting this? Very subtle. हर पेशेंट में explicit feared consequence शायद ना हो. In OCD I'm talking about it. But हर किसी के पास ये distress रहता है. But why don't target you as an SUD level there? But we only do the SUD level. See, the point is that वो pre-post मैंने बताया नहीं, यहाँ पे लिखा हुआ था. जब भी हम वो करते हैं ना, all these things we always write pre-post. A pre-post in the sense, I was expecting this to happen. Then I did the exposure. One post में what actually happened. सोचा था my distress level will not come down. वो patient खुद लिखे अपने language में, लिखवा उससे. My distress won't come down unless I do this compulsion. 1 घंटा तक वैसे ही रहेगा. आपने उसके साथ किया, distress came down or not, तो पहले अपने आप में ही वो mismatch of expectancy हो गया. But when that will happen, if you put as an goal of your therapy, if you're in the feared consequences, so इससे पहले लिखवा वो चीजें कि do not always target explicit feared consequences. देखो ईचिंग वाला एग्जांपल मैंने आपको वही समझाया, पहले मुझे बुरा लग रहा है कि वो बेचैनी हो रहा है, पहुंचूंगा तो जाके खुजली होगा, लेकिन अभी जो बेचैनी का मैं क्या करूं, तो उनको लग रहा है कि ओनली दिस थ्री थिंग्स ओनली कैन डिक्रीज माय थिंग्स, दैट्स व्हाई आई गोइंग टू चैलेंज इट, इवन इफ यू आर नॉट डूइंग एनीथिंग योर डिस्ट्रेस विल कम डाउन. So target the distress component also as in feared consequences. You convert that to feared consequences. How? That is a statement, operationally telling the statement. Until unless I do this compulsion, my distress is not going to come down. Are you getting it? अब उसको तुम जो भी फिट करवा लो अपने पेशेंट के हिसाब से. So this is also one of the things up to be targeted during the exposure. Secondly, an explicit बीमारी हो जाएगा, accident हो जाएगा, फलाना फलाना फलाना. So we are doing that. You are always targeting two fear. One is distress level, other is the explicit fear consequences. And when you're doing the SUD itself, that is also working like an five. We were asking, now the anxiety went high and came down. Even if 10% we come now, even if in the first session it may not reduce to 50%, 10% we can now. That is a success rate. उनको लगा था ये 90 से 900 हो जाएगा. But okay, now at least 90 became 80. That's the first success. Everybody likes to see the success. So in the one therapy session, you can even show to them the success there. This is how, but only when you actually thought of as an, feared consequences. You have to convert that in an operational way. Got it? Okay.
So she used to believe that if she has eye contact with any man, she will probably kiss him and
Kiss
she will be bared in front of him. Something she used to believe for 3-4 years, but there was no compulsions as such. Something I could able to find out. So how can we proceed with these patients?
I'll tell you, before explaining these things, in my short career, I have found sexual and harm compulsion as the easiest to treat. Easiest to treat, and this is very easy if you convert that in a proper, this feared consequences. Mostly they'll have certain compulsion. I'll take for granted there is no compulsion. I'll take for granted even if there will be. What is feared consequences? If I see somebody else, then I may go and kiss the, talk or think about anything, I may kiss about that. Second, so avoidance to ho raha hoga na. If I keep on sitting there, then definitely do that. Yes, if I'm going to sit near the person, definitely I'm going to do that. Mostly the patient should be using in a multiple avoidance behavior.
Eye contact nahi
Eye contact. Okay, fine. Maybe I'll sit there. I'll try to think about the mental level. I'm going to actually kiss the person. I am going to actually kiss the person. Mentally, I'm thinking about that. First is also distress. That is the distress is happening. See, you might not have challenged this one. This will keep on distress increasing. And second component is actually go and kiss someone. The two, you have feared consequences. Let the person sit from a little distance from the person. Name as a dummy therapist or the co-therapist. Another person, he has to look towards the eye. You can ask him that, within how minutes, if you are following innovative learning model, within how minutes you are going to kiss somebody. Maybe 2-3 minutes. Okay, let's do the exercise for 2-3 minutes. Okay, are you getting it? 3 मिनट तो हो गया, आपने तो किस नहीं किया, ठीक है, और कितने मिनट में आप किस कर सकते हैं, आपको लग रहा है, so maybe 5 minutes more. Okay, let's do it more for 5 minutes. This is how we do in the innovative model way. But in the classical EPT, it is more easier to do. So there, you simply have to watch the SUD level, distress level during the exposure. You'll be sitting in before but you have to write in a copy. You're thinking my distress would not come down. If I keep on looking towards the eye, I won't feel, my distress would not decrease down. That is the first thing. See, do not go directly to the feared consequences, explicit feared consequences. Even keep on looking towards eye contact, my anxiety will be too high and it will keep on increasing. Secondly, I'll commit that. Okay, now the person has to look, now the exposure, the person has to look towards the eye. Every 5 minutes or 2 minutes, not necessarily 5 minutes, in this case 2 minutes is enough. Every 2 minutes you keep on asking about the SUD level. अभी कितना आपको एंजाइटी, कितना बेचैनी लग रहा है, 10-15 मिनट में बहुत कम हो जाएगा. Sexual harm impulses reduces very rapidly most of the patients. चलो आधा घंटा तो हो गया, 50% now and anxiety has been reduced. तो पहला आपका जो feared consequences वो गलत हो गया. आपका डिस्ट्रेस कम हुआ एक्चुअली, ऐसा नहीं कि बढ़ते गया, थोड़ा बढ़ा उसके बाद कम हो गया, अब आधे घंटे में आपने किस नहीं दिया. So two things now came down. So the second exposure will give him, it will also be little more comfortable than the previous one. So done repeatedly, it will be much better. Sexual harm impulses, the easiest in mind short carrying, because it always has an explicit consequence. Yeah.
So that idea, sitting next to a person, I'm looking at the person, I have not kissed them. So that does come down. But for me, there is difficulty when with sexual obsession there is blasphemy connected. The thought itself is something that is sinful. Why am I having this thought itself? So we worked on this. Ki, "Okay, I have not kissed anyone. I have thought this, but have not kissed anyone. But because I'm thinking this, it is a sin. I'll be sent
more
to
of thought
hell."
action fusion model. This is again a little bit cognitive work is required on that. It's a moral thought action fusion. Thinking about the act is same way of doing the act. तो मैंने बस सिंपल से ये पेशेंट को बोलता हूँ, बहुत ही छोटा एग्जांपल है. Since you're asking, I'm lost, but your time I don't know. I'll tell you the answer. I tell them you went to a mall, shopping mall, okay? जानबूझ के आपने चोरी किया, okay? चोरी किया, बैग में रख के लिखा है. And second time while shopping, something accidentally fell to your thing. Now you tell me which is more sinful or which is sinful, first or second? First was sinful, second तो अपने आप गिर गया. आप चाहते नहीं थे. अब now I'll connect to the patient. आप चाहते हो thought आए कि ना, आप नहीं चाहते हो ना, this is not sinful. So having this is the cognitive component, but basically क्या होता है ना, even you patient see more, and to connecting both of the examples, also another exposure. Let's think about that. Let's me think about internal and external cue, not only sitting the person next to him. Let me think about going into kissing. It's more heightened cue of hierarchy of actually increasing the level of anxiety there. I'll think of actually kissing him. Here, I actually think of that blasphemous thing. सोचने से मैं जानबूझ के नहीं हो रहा. और दूसरी कंपोनेंट में ये मैं ऐड कर देता हूँ, आपने काम किया, बच्चा ने काम किया, लेकिन उसके पापा ने उसको बोला जबरदस्ती काम करने के लिए. बच्चे को लगेगा कि पापा को लगेगा. मैं पहले उससे निकलवा लेता हूँ आंसर, फिर मैं अभी डॉक्टर होने के नाते मैं आपको बोल रहा हूँ, पाप लगेगा तो मुझे लगेगा, आपको नहीं लगेगा. So this is how we connect the things and go back. This is the more cognitive component than the exposure component. Yeah. I mean, it's good that I'm asking, but I should not taking others' time. I don't know it's ethically right or not.
Any more questions? Okay. So, sir, at the beginning of the session, you made us imagine two situations, taking us back to our hostel parties, where yes, the emotion process theory worked, and jahan maine fine pay kiya tha, I was teleported there. So we all connected, and the sessions, at times I felt like going there in the audience chair and then attending. So interactive were the sessions, and very informative. Needless to say, seeing the overshooting of the time where it was a 1 hour session that continued to be a 2 hour session, it itself is a compliment to how well we were, enlightened about the subject. So thank you so much, and I think Sir deserves a round of applause from all of us. And that also addresses one of my questions, the reinstatement of fear एक जगह हम introduce कर रहे थे, and that raises the anxiety, and we know that it will raise the anxiety of the patient. तो अभी ऐसा तो नहीं बोल सकते patient को, मुझे देखो ऐसे तुम्हारा ना थोड़ा घबराहट बढ़ेगा और फिर वैसे, because that again I think that disbalances the treatment expectancy of the patient a bit. And that also happens in somewhere when we give the pharmacotherapy, certain agents which raises the anxiety, which are actually meant to be the SSRIs to lower them. तो initially वो होता है, तो वो कैसे फिर patient को बताना है, या फिर वो उसको कैसे address करना है फिर? Okay. क्या address करना है? मुझे पता है कि patient की अभी मैं एक feared stimulus जो instill करूँगा, anxiety बढ़ेगी. Where he was going down the line with his anxiety, he was जो उसका उस पर जा रहा, तो अब anxiety बढ़ने वाली है उसको, मुझे पता है. So अभी उसको कैसे address करें? देखो
The
तेरी
conceptualization you might have cleared that during the
Yeah.
exposure, anxiety should happen. Until
Hmm.
unless anxiety is not happening or not learning.
Hmm.
That is the basic thing we will be telling. So every exposure will increase on anxiety. But he has to face the experiment with the pure consequences happening or not. So that's what will be focused on the conceptual part. Secondly, we advise most of the treating team not to SSRIs are fine, but not to give benzodiazepine in the first 3 weeks. I mean the thing is that if it's a benzodiazepine is on already in the benzodiazepine, he'll be not be having that much of an anxiety. So SSRI always takes 3-4 weeks of time.
Yeah, and only when they settle with that, then we send them for the psychotherapy
That
sessions.
is actually not the right thing. Why I'm telling you, no?
That is actually
First
what is
3,
practiced,
4
which is
that's
not
what,
the
you
right
know,
thing.
In the first 3-4 weeks is the great time of
It should
therapy
work in
to,
conjunction.
because SSRI is going to take time,
Yes.
right? So it's better that you have done in the first 3 weeks of treatment is more towards an golden opportunity for therapists. But we go, I understand, and there's an old concept of reduce होगा तभी जाके वो
तभी
डिप्रेशन के लिए ठीक है
Hmm.
बट एंग्जाइटी
Anxiety
के
के
लिए
लिए।
पहला 3 हफ्ता वो ज्यादा इंपॉर्टेंट है क्योंकि एक्सरसाइज को टाइम लगेगा तो
साथ
आपको
में
अपने
benzodiazepines के साथ
अब वही प्रॉब्लम हो जाएगा ना इसलिए मैं बोल रहा हूँ तब बेंजोडाइजिपिन नहीं देना
Hmm.
we actually want those 2-3 weeks of non things to be more you'll able to understand you'll get okay during
ये
the
तो दवाई काम कर रहा था ये मैं नहीं So
नहीं
that
कर वो
sense of self
avoid
control वो नहीं
means everyone mostly understands
Yeah.
it. They don't prescribe benzodiazepines in the first 3 weeks of it until unless वो बहुत ज़्यादा हो जाए and terrible हो रहा वाला काम. Are you getting the thing?
I am getting
The
it.
first 3 weeks is more important. Then you'll get able to connect. Okay, now medicine भी हो रहा है. Similarly, medicine overall, but when the momently anxiety हो रहा है, even if it's okay, fine. Even after 3 weeks, I'm talking about it, right? Okay. Even if the SSRI has started already effect. But whenever there is an upshot of anxiety, even he's taking SSRI or not, when he's going to face anxiety situation, there will be increase of anxiety. So here the moment to moment experience matters. Now already having anxiety, but during the exposure, it came down. So that will also give the contribution towards therapeutic effects also. Moment to moment. SSRI, I mean, the moment he is going to expose to something that he is fearing, anxiety will shoot up. Even if no matter how dose of anxiety is in, until unless is a high dose of benzodiazepine. That is a problem of benzodiazepines, but other things are okay. Exercise, it's more.
I understand. Thank you so much. It was an honor chairing the session, sir. And thank you.
To everyone for a patient hearing.
Samantre, for that insightful session. I know all of you enjoyed it. And also, our heartfelt thanks to our chairperson, Dr. Adil Rai, for guiding the session so gracefully and sharing his valuable observations. With that, we would conclude this session. I would like to invite Dr. Tarana Jain to kindly come forward and facilitate our chairperson and our speaker for the moment with a memento as a token of their appreciation. Please, Dr. Adil Rai, can you come? Dr. Samantre, can you please come? Thank you, everyone. You may please go for the next session.
Can I mail it to you?
Relapse prevention therapy, understanding the Gorski synapse model. This model offers a structured and evidence based framework for understanding relapse as a process rather than a single event and for guiding long term recovery through integrated therapeutic strategies. For the same, we are privileged to have as a chairperson Colonel Dr. Anurag Timothy, an esteemed addiction psychiatrist and HOD at Base Hospital. Dr. Timothy completed his PhD from NIMHANS and has served extensively across military and government hospitals. With numerous publications and a distinguished clinical and academic career, he brings exceptional expertise in the field of addiction as well as relapse prevention. Welcome, sir. We are also delighted to introduce our speakers for the day. Our first speaker, Ms. Ishita Agula, is a licensed clinical psychologist with an MPhil from JSS Academy of Higher Education and Research, Mysore. She specializes in providing therapy for individuals with substance use disorders and co-occurring mental health conditions, drawing upon a client-centered approach. Her clinical expertise extends to working with couples, families, and groups with a strong emphasis on empathy and relational depth in therapy. Our second speaker, Ms. Raksha Rajesh, is a clinical psychologist with over 6 years of professional experience. She works extensively with adults facing trauma, anxiety, depression, relational difficulties, and personality challenges. An MPhil graduate from JSS Academy, she is also a mentor and educator actively supervising early career psychologists. Her psychoeducational and awareness content on social media has reached and inspired numerous students and mental health professionals alike. I now welcome our speakers to take us through the session. Hi, good morning.
Hello, good morning, everyone. I hope I'm audible to everyone. Yeah. So, we are going to talk about relapse prevention therapy, something that all of you would have studied at some point of time in your educational journey of becoming a therapist. But today, we are going to look at it in a very different lens. Um, so, when we talk about substance use disorders, when we talk about process and substance addictions, we have to keep in mind that our role as a therapist, our role as a clinician matters a lot. Our idea of how we look at relapse, how we look at recovery is very, very important. So, to start off today's symposium, let's look at some of the myths that exist in relapse prevention therapy, shall we? One of the most common myth that we look at when we speak about substance use and addictions is that abstinence is recovery, which it is not. Abstinence or taking a break, being clean, is one of those many, many, many processes that exist in the journey of recovery, but in itself is not a part of recovery. When we talk about recovery as a process or relapse as a process, relapse starts way before a person ends up picking up that drink or starting to use again after a period of being abstinent. Is anyone here aware of 12 steps model of recovery? Okay. When we talk about 12 steps, a brief idea for whoever is interested or they don't know about what 12 steps are. 12 steps is a very, very famous model of recovery, generally in religious institutions as such. Very, very highly commended. But at the same point of time, 12 steps is not the only and the best way to recovery. There is so much more to substance use and the journey in recovery that exists over multiple decades of work through clinicians, their work over the world, right? Relapse is a part of recovery. How many of you have heard this? Yeah? Relapse is not a part of recovery. If you have relapsed, that means the recovery journey stopped way before you picked up that train. So, the myth that a lot of clinicians and therapists working in the addiction space carry is that relapse occurred and that's why the person has got into substance use again. And that's not true. Relapse has been occurring way before that. Okay, and we are going to look into that. Ishita will be covering that in her side of the presentation. Client failure is a result of client's lack of motivation. Interesting. One of a very interesting spaces that we work in is if your work as a clinician, if your work with a client is only motivational interviewing to help them stay clean, and I'm going to put that in air quotes, clean, and only motivational interviewing would not be helpful for the client's recovery. Is it one of the many tools? Of course it is. And we use that too in the space with the clients, but it is not the only whole and soul work. It is the way that you talk to clients, it's how you use systemic approaches, interpersonal approaches, process of how they deal with the entire stage of relapse, which also needs to be considered. So it is not just the client's motivation, it's how they are equipped to handle their triggers, the awareness of triggers, and the stages which also precede the physical relapse, as we say. One of my very favorite quotes that we always present in our presentation. If you sober up a horse thief, what do you get? You get a sober horse thief. In that same way, if you sober up an addict, you get a sober addict. You don't get someone who's working actively in recovery. So just being sober is not enough. Yeah? I hope you're all with me. Yes? Okay. So since we are talking so much about what recovery is not, let's see what recovery is. Yes? Recovery is based on a four-legged stool, like we call it. It's biological. We have to manage our withdrawals, right? Social, spiritual, and psychological. When we talk about recovery, all these four aspects have to be considered. Any of these four are missed, the chances of relapse is high. It is hard. It is not easy. For clients, especially when they come to the rehab, they come there in a very close knit environment to be catered to, they're taken care of. But when they go outside of the rehab, there is so much that they have to face. They're going back to their life. Life as they knew before coming to the rehab was the life that they were living as an addict. Also, not the word that I generally like using, but since it's very frequently used, the word addict, something I'm bringing in. Most people fail because they don't follow through. And that is true. The work that is done at the rehab, the work that you are doing in the OPC with your clients, if the work is not done, again, work, meaning how do they process their emotions, how do they understand the triggers outside of the therapy setting, if that is not happening on a day to day basis, recovery will get tough. It needs to be fluid as your life changes, and one size doesn't fit all. Everyone's environment, everyone's relationships are different, and that needs to be catered to when you are looking into someone's process of recovery. And you do need a team. As clinicians, there is always, even though we do say about multidisciplinary teams, and I'm going to take that with a pinch of salt while I say that this on the dais today, there is a lack of lies in work with a lot of team members. And all hands on deck has to be the only philosophy that is followed. But at the same point of time, we always say to the client, you alone can do it, but you cannot do it alone. You need the support systems, you need the systems in place, which are very, very important. What is relapse? A lot of times when I talk to clinicians, their idea of relapse is always like, oh my god, the client has relapsed, everything has gone to drain. And that's not true. The client tells you what is happening way, way, way before that. So relapse is a process. It is not just one event. It is not just picking up the drink, going back to substances, gambling addiction. It's not going back to just doing one bet somewhere in one of the poker games. No, it is not. It has started way, way, way before that. And other people do notice your process of relapse before you. Your family members, they do give you clues. You're getting more angry. You will get into strained relationship with your friends. Your workplace. How are you behaving in your work where you spend around 10 hours of your day almost? You'll get cues everywhere. Your client does. So your interview style in every of the subsequent therapy sessions also matter. What cues are you picking up for the client? When we talk about the client's process of relapse existing before that, how are you presenting yourself as a clinician in every of the subsequent therapy sessions? Also play a role for you to help the client understand where some of the warning signs have been presenting before that. There is no such thing as lapse. There's always going to be a relapse. There is no lapses when we talk about relapse prevention therapy. The clients, to understand what relapse is, we need to help them understand that a relapse can be reversed. That gives the agency. Okay, fine. In the journey of someone being clean, they might have a lot of relapses that might happen, but how you talk to the client becomes very important. How they understand relapse becomes very important as well. We need to know that relapse can be reversed and they can go back into their journey of recovery. Yeah. We have spoken about relapse, we have spoken about recovery, we have spoken about certain myths that we carry. So, since we are speaking about the processes that include in the relapse stages, I would invite Ishita to take the dais and walk us through the next half of the presentation.
Good afternoon, everyone, and thank you, Raksha, for debunking some of the myths of relapse and recovery. But I'd like to start by talking about how relapse is very, very misunderstood. Even recovery is. However, our focus is going to be on relapse. So today we'll understand what exactly relapse means. Am I audible? Yeah. Okay. So I like to believe that relapse is a process. What that means is there are stages to it. It starts with something and it ends with usually or unfortunately with the drink or the substance of choice, right? The middle portion is something that I like to call as warning signs. Okay, now let's take some time to understand the process of a relapse. A relapse has three stages, starting with an emotional relapse. This is where the client has just stopped their recovery efforts. Difficult emotions that are usually stressors or triggers to substance use are not being managed well. For example, anger, sadness, frustration, stress, etc. They're not doing the usual mechanisms that they need to do in order to take care of these emotions. Some of the examples that I have is from a client that I have worked with. They were dealing with a very intense relationship and a lot of tiff with their partner, and they would struggle to express their emotions to the partner. They would hold on to the resentment, they would hold on to the anger and the hurt. When these emotions have no place to go, where are they going to be? They're going to be in here, right? And when it is not managed or expressed for a very, very long time, they're all going to build up. This leads to progressing to the mental relapse. This is where emotions are already at a high and life has started to seem very miserable. So, what do? We start fantasizing. We start overestimating our ability to manage emotions, our ability to manage stressors, and start reconnecting with people. We go back to the people that we used to use with, we go back to the places where we used, and just go back to the same space, but give ourselves the impression that, hey, I'm fine, I'm not using yet, I'm absolutely fine, this is okay. This stage is a lot of overconfidence, fantasizing, minimizing the intensity of the addiction, and overestimating our capacity. Sometimes clients can also have the sense of life is very bad. It is still very bad. Life was bad even when I was using. Life is bad even when I'm not using. What am I doing here? Eventually, it leads to the drink or the substance, a physical relapse. A physical relapse is nothing but just return to use. What the stages of relapse helps us understand is the using is not actually as important. What happens before is where I can work. That is the important part. And as a therapist, that is where I would want to focus. Because this is where I can do a lot of work. How can I stop a client from using or relapsing when they are already in the physical stage? I think at that point the only thing that would work is restraining them. And that's not feasible. Right? The most work happens in emotional and mental. Understanding these stages of relapse is so important as a clinician and as a client so that I know where I can stop it. This is where the RPT theory steps in. Terence Gorski is the one who founded this model, and he talks about relapse being a process, relapse having stages, and understanding, having a conscious awareness of these triggers and these stages can be very helpful in preventing a relapse. And that is what we are going to be talking about today. Great. So let's start with the assumptions of the model. So the first thing is recovery is about having a meaningful and a comfortable life without drugs. Abstinence is not recovery. That is just you not using. However, if the stresses are there, if the difficult relationships are there, if the unexpressed hurt and all the emotions are there, you're just not using. However, you still continue to lead a very miserable life. But recovery is about doing everything that you have missed while you were actively using. Abstinence is a prerequisite, but not enough for full recovery. Again, adding on to the last point. I need to be clean. I can't use any substances, but that's the bare minimum. Relapse starts long before the actual use. This is where the emotional and the mental stages are important. If I am exhibiting any signs, that means I have relapsed already. I might have not picked up, but I'm still relapsing. When pain becomes unbearable, self-medication seems like the only option. I think some of the narratives from my clients have always been, I knew I was wrong. I knew I shouldn't have picked up, but what else I could have done at that time? There was no one else. It was the easiest thing for me to do. It was the quickest way for me to relieve my anxiety, for me to forget my worries, and for me to go to sleep. That's the only thing I could have done. The client is usually out of control before the drug use begins. Like I said, again, the emotional and the mental stage of relapse. Great. So when we adapt the RPT model to our structure, we follow these six steps. We start with the stabilization. For any work about relapse or recovery to start, the client needs to be stable. What that means is we deal with the withdrawals, any other physical concerns that they might have. Usually, depending on the use, it takes about 1 to 2 weeks. Assessment, any history taking, any medical or psychometric tests that they have to do are done here. And then very quickly we start with the relapse education. Relapse education means talking about the stages of relapse with the clients, getting them to identify what is their stages, what are their triggers, what are their warning signs. And then we get to my favorite part, that is the warning sign identification and management. Once that is done, once I know what is my cycle, what is my timeline, I can quickly start on building my recovery plan. Again, a recovery plan, not just an abstinence, but a recovery plan. Great. These are some of the techniques that I used in RPT: active listening, shame reduction, getting them to identify that the relapse is all right. We can work through it. Yes, the stigma is there. However, I need to now focus on understanding myself and forgiving myself first. Introducing and utilizing the stress monitoring. We all know that stress is a very, very big part of substance use and relapse. So I need to understand what are my levels and how do I monitor them and how do I work it through. Then we do something called as the recovery relapse calendar. Again, one of my absolute favorite techniques. This is where we get the client to start drawing their own timeline. Usually we target 3 to 5 episodes, like previous episodes of relapse and recovery, and to understand throughout the year what has happened. What are the triggers? Why did they pick up? What happened before that? Some of the key themes that have emerged are weather, festivals, any holidays. Most relapses in India happen during Diwali, Holi, because the use of, in Thandai, etc., and New Year's, right? When they identify these key components, the recovery relapse calendar helps them a lot. We also do something called as learning from past efforts. These efforts can be anything. If they have tried to regulate it, I will just do 2 drinks in the weekend, or I'll just drink on festivals. Even those are efforts. Or they have tried a rehabilitation center, they have been to treatment before. I'll reserve the identification and management for a bit later. But then we move on to recovery grid and recovery planning. Again, very essential steps in understanding what my recovery is going to look like. Not everyone's recovery plans are the same. Today, because of unfortunately we don't have much time, and maybe some other day we'll talk about the other steps in very detail. But today we'll talk about the warning identification, warning sign identification, and management. So we use something called as warning sign cards. Okay, I'll show you a picture of what that looks like. However, the whole idea is for them to sit down, look at their past episodes, and identify what has led to their relapse. The best statement I like to give to my clients is, I know I'm in trouble with my recovery when, and whatever comes to their mind. In our center, we do this in group therapy as well as individual therapy. So they all sit together, they think about what could be these 10, 20, 30 warning signs for them. And it can be absolutely anything. I know I'm in trouble with my recovery when I don't go to sleep at 10:30 p.m. I know I'm in trouble with my recovery when I have missed my AA meeting. I know I'm in trouble with my recovery when I have skipped an AA meeting. Or I know I'm in trouble with my recovery when I have not called my support group once a week. It can be absolutely anything. I know I'm in trouble with my recovery when I've not journaled. So this is what the warning sign identification card looks like. This is just the side one. So this is the part where they record all the dysfunctions. Okay. If you can see, the description is, I know I'm in trouble with my recovery when I give this to my clients, I say, you know what, just write whatever comes down. Whatever comes to your mind, we are going to start noting it down. It doesn't matter if we are just repeating things over and over again. We come up with at least 20, 30, sometimes 60 cards too. And then they go on to noting down the thoughts, feelings, urges, action, and reaction. I have an example, maybe we can explore that. As you can see in this one, I know I'm in trouble with my recovery when I convince myself I don't need to keep working so hard on my recovery to get complacent. The thought is, I am fine, I am all better now, I am cured, this sucks. The feelings are very proud, excited, and even angry sometimes. The urge is to slack off, procrastinate, hide out, because they don't have to do any more steps. Action is they do all of the above. They slack off, they procrastinate, and they hide. And the reaction is people get concerned, they get angry, but wonder if they are right. As you can see, in this card, there is no mention of drinking, using, or having any thoughts. However, this is still a very relevant warning sign identification card. And because this belongs to the, any guesses, which stages of relapse? There are thoughts coming in. Mental. Yeah, this person is going there. Very soon, in probably weeks or days, they might start using again, if not regulate. The side two is, I like to call the positive side, because this recalls all the ways of managing these dysfunctions. Again, RPT is very focused on the warning sign identification. However, all our other psychotherapy techniques also belong here. So the thought, obviously, a lot of people would use cognitive restructuring for emotions. Any emotion regulation techniques can come in. And the same for urge, action, and reaction. This is one of the most important things in the RPT setting. Once I know my warning sign, once I have identified my warning signs, I can work on them. I can share this with people. I can include my family. I can include my therapy team, my peer support, and get as much resources pulled in as I can. Again, unfortunately, because of time, I can't really explore the other bit. However, I think this catches the essence of the RPT model. So that is what we do with our clients. As many cards as they can create, the better. And then this becomes the recovery plan. All the things that they have mentioned on the side too can be a part of their recovery grid. The whole point of this workshop is to understand that relapse is understanding relapse is very important. If I don't understand my relapse, I don't understand my recovery either. Once I have my warning signs down, I can work very actively towards it. And again, I don't have to pick up to say that I'm in relapse mode. I can reverse it back. I can work very actively. Relapse does not mean that all my efforts are down the drain. That means I have to just be a bit more mindful. So the quote that I believe the most that encapsulates this is, the only way out of a relapse is through the relapse, understanding it and learning about it. Because if we don't talk about it, then we are doing an injustice. Okay. Thank you all, and that's all from my side. Any questions? Yes. Yes.
Hi, good morning, ma'am. And first of all, thank you for your presentation. So my question is, when you talked about the emotional stage of relapse, you mentioned, at least it was written in the slide, it said over the top happiness.
Yes.
Could you please throw some light on that if possible?
Yes, definitely. I think one of the most ignored emotions in recovery is happiness. A lot of my clients have said that they have relapsed when there's a good news, when they have gotten a deal, when there is some party, right? So managing happiness is also extremely important. Understanding the impulsivity that comes when I feel too happy, when I'm not thinking rationally. That is what I mean when I say over the top happiness. If someone finds that their relapse is happening the most when there is a celebration, there is a party, I know I have to work through. I know people have to be around me when I'm at a party. I have to have a sober buddy. I have to have my partner. I have to have my mom, dad with me to tell me that, hey, it's okay. You are happy. You can express it in very other ways too. You don't have to chug a couple of drinks and dance.
Yeah, does that make sense? Thank you. Yep, there.
Hi, thank
Hi.
you for your presentation. I just wanted to ask why the lapse relapse part of it not a part of this model? Like, in what way is it not congruent? Because I think many people do experience that abstinence violation effect, right? Like that I've already abstained, so I've already relapsed. So what is the point of continuing? So I did find that quite helpful. I understand why theoretically it might not fit, but what are your take on it?
Thank you so much for asking. I really like that question. The reason why we don't talk about like lapse is a different thing than a relapse is because it's a very confusing and honestly an unnecessary term, I believe. Because this gives people the permission that, hey, I can have one drink. You know, it's a lapse, it's not a relapse. My one drink does not mean I have to start my efforts again or I have to sort of sit down and understand what went wrong. It, in my experience as well, it gives people the permission that, hey, it's fine. I can ignore it. This was just one, this just happened once. So I can go about my day, my week without worrying about what led me to that drink. The whole idea about RPT or the Gorski model is to understand that you picked up that drink. That is where the relapse ended. It started before. And what got you here to that even one drink, even one sip is important. And that's why the term lapse is not used. Yeah, thank you. Yeah.
First of all, I want to congratulate both of you for such an enlightening and crisp symposium, and it was really helpful to understand a different model from the ones that you've learned in our training years. My question is that when it comes to, say, behavioral addictions or even some forms of substance addictions, I've also seen a comorbidity with conditions like neurodivergent conditions like ADHD and having behavioral addictions. So, would the relapse prevention model still be applied the way it is applied for others, or would there be some alterations, and how would we do that?
Obviously, it will largely be the same. The warning signs will look a bit different. So if this is someone who is struggling with ADHD and they, for example, take some medicines to manage it, one of the warning signs can be I am taking my medications late, I am missing my medications, or I'm not visited my therapist, I have not done my usual cognitive exercises that I have to do. If it is related to their diet, I have not taken care of my diet. So the model largely will be the same, but the warning signs can look very, very different. Yeah, I'm seeing a very high comorbidity. ADHD is so high, especially people with polysubstance use, with stimulants, right? So we have to be very mindful about these things as well. And psychoeducation, making the client and the family understand why you have to be mindful about these signs. It's not about just them going out late at night and probably returning home late to start thinking that there is something going on. Even these small, small signs are just as important. I hope I have answered your question.
Thank you so much.
Sorry, my voice is like really bad right now. But even at the therapy setting, right? If we have to take the client outside of the context of the rehab, for example, outside of the inpatient setting, because I generally work at the outpatient center. When we are talking about clients that you see in therapy sessions, for example, asking, even understanding how neurodivergent clients deal with the after effects or um, not just focusing everything on the neurodivergence, but everything that surrounds the neurodivergence and how they deal with the distress will also tell you that there is some level of addictive behaviors that you can see. One of the clients that I'm actively working with, she was never diagnosed with high functioning autism until 2 weeks back, and she has been an addict for a while now. So yes, like she said, the warning signs will look different. The management might look different, but also to understand how neurodivergence plays a role to help them and what are they seeking the help for can help. Just modifying the model for them. Yeah.
Thank you. Any other questions?
Yeah, thank you very much. Do we have time? Right. Okay, sure. So, I have been practicing addiction for last many years. This is a very good model, relapse RPT. So there are many such models, Marlet's model, right? This Gorksky's model. There are other few models. But what in our practice we actually focus on is why does a person drink, right? So that the person, so many of you here, we drinking is a social thing. It's okay to drink. Smoking, tobacco, it's an okay thing. We have these shops, panwala, at every nook and corner, right? It's okay to do these things. Now the thing is, why do we drink or why do we smoke? There may be many reasons. When we start asking the individual, why do you drink? We may say that I enjoy drinking, right? So the next question is enjoyment. Where does the enjoyment come from, right? So we all enjoy. At present, if I ask somebody, say anyone, what are the things that give you enjoyment? Anyone? Okay, playing badminton, yes. What else? Say again. Dancing, yes. Painting, yes. Listening to the music, yes. Right? So there are so many things that we enjoy. And one fine day, when the person is introduced to alcohol, something gets added to that I also enjoy alcohol. Right? Right. So now he starts enjoying alcohol. Gradually, over a period of time, dancing breaks off. Playing badminton, he is not able to play badminton. What else was there? Painting, right? Painting also goes away. Now the whole focus comes down to alcohol, yeah, or any other substance. So maybe 5 or 10 years down the line, if I ask the same person, what do you enjoy? Right? So all these things are not there. The only enjoyment comes from alcohol, right? But what does the alcohol give you? So at the age of 18 years, when he started drinking, what gave him the enjoyment? Maybe he was calmer, right? Maybe he had a lot of anxiety and that time the anxiety came down. Or maybe it was just the high, right? Or it may be something else. So that maybe answers the question that there is a lot of ADHD seen in addictive disorders, right? Because what does alcohol do to the person? Calms him down, right? So the ADHD level goes down, the attention improves, hyperactivity goes down, and then he says, yes, I can manage my ADHD with alcohol. And then he starts to increase. A person who is socially anxious, so maybe standing here, if I become anxious, if I take a drink before that, right? And I chew some elaichi or something, right? I would feel calmer. I would be able to give my presentation, and that becomes a habit. Every time in a social situation, I would have a drink or would smoke or would take heroin, whatever it is, right? So the asking the person, why do you enjoy alcohol? Why do you? What is the reason that you started with? I think that is the most important thing in relapse prevention. If we are able to address that, maybe after that the relapse prevention will be easier, and then we follow all these things. What I've been told, I think things become easier after that. So this is what I apply in my clinical practice, because I consider, and so I was in a PhD. My guide used to say this, that Alcohol or any other substance is just the epiphenomenon. Epiphenomenon is the 10% of the iceberg that you see, right? There is a sea level, only 10% or 1% is above, the whole of the iceberg is down. So, alcohol is just the epiphenomenon which you see, which the person has come with. But the everything is down below, which is the ADHD, maybe the depression, maybe the anxiety, maybe the relationships, maybe the personality issues. If we address those, maybe the alcohol will go away on its own. And probably that's what we need to focus on, relapse prevention. Do I make sense?
Thank you to all the participants for your engaging questions and thoughtful input. We once again extend our heartfelt gratitude to our chairperson and speakers for their enriching contribution to today's symposium. I would now like to request Dr. Deepika Srivastav, our Assistant Professor IBHAS, to kindly present a memento to our distinguished chairperson and speakers as a token of our appreciation. Ms. Ishta Kuda, I would like to request you. Ms. Raksha Rajesh, please come for your memento. With that, we conclude the session. Thank you everyone for your kind attention and participation throughout the session. We will be starting with scientific paper session here. So if you all want to join, you can please wait. Otherwise, you can join other sessions in other halls. Latini also come here. All my Everybody look at this camera. Just get selected. Okay. 1 second. Everybody look at this camera. Smile. Smile. Thank you.
enthusiastic gathering of budding researchers and professionals committed to advance psychological sciences. We look forward to an intellectually stimulating session filled with insightful discussion. It is my absolute honor to introduce the esteemed chairpersons for this session. Dr. Venkat is a trusted psychiatrist in Hyderabad. He has been there in 18 years of journey. He has completed PhD in psychology and is currently associated with consultant clinical psychologist in Hyderabad. We are delighted to welcome We are also delighted to welcome Dr. Nishtha Kumar, consultant clinical psychologist, gold medalist, and assistant professor at Amity University, Noida. Ma'am is currently not here, but she will be joining us very soon. So we will start with our presentations. Each presenter will have a total 10-minute time duration, comprising 8 minutes for presentation and 2 minutes for discussions and question and answer sessions. So without delay, let's commence with the paper presentation for this session. Our presenter one is Ms. Karuna N. Nair. You please present them.
Good afternoon. Good afternoon, respected attendees and the audience. So, I'm going to present a narrative review on the topic A Decade of the POCSO Act, Evolution, Jurisprudence and the Psychological Dimensions of Child Protection in India. Along with me, the other co-authors are Jagriti Khurana, Tejal Sankvi, Dr. Sumitra Singh and Dr. Sonia Kaur. Child sexual abuse is a pervasive public health and human rights issue. Pre-2012, there were Indian penal codes, but it lacked child-specific protection. So, POCSO Act, which is Protection of Children from Sexual Offences Act, is developed in 2012, filled this legal void, recognizing the children's unique vulnerability. So it is very important for us to examine how far the Act has evolved, what challenges persist even now, and how does the system address the psychological needs of child survivors. So POCSO Act is India's first dedicated law against child sexual abuse. It applies to all children under 18 years and it creates a child-centric, gender-neutral statutory framework for sexual offences against the children. So before POCSO, child sexual offences were governed by IPC section 354, 375 and 377 and regional acts like Goa Children Act. So these IPC sections are not child specific. Okay, so section 354 is for outraging modesty of women and 375 is rape and 377 is immoral unnatural offences. And the Goan Children Act was regional, it was only in Goa to protect children from tourist and child prostitution. But these laws and these acts lack the clear definition of child sexual offences and protection for male victims and recognition of psychological and digital abuse that is happening in children in India. So these are the objective of our review to synthesize evidence on the evolution of the POCSO Act, jurisprudential interpretation, implementation challenges, psychological outcomes and service responses. These are the literature review that I have taken. From these studies, it's found that there are systemic delays and implementation gaps, which is seen, and 63% of the cases are pending for more than 1 year. And it also reported limited trauma sensitivity among the officials like police, prosecutors, and judges, and highlight that the courts often overlook the trauma-related behaviors like delayed disclosure, emotional withdrawal, affecting the testimony credibility. This is the methodology that I've used. Study employs a narrative review incorporating a targeted search of case law, legal commentary, and psychosocial research published between 2010 and 2024. So this is the evolution of the POCSO Act. So enactment was on 2012, where we got a comprehensive gender-neutral protection against CSA and child sexual abuse. So under POCSO, there is no gender-specific laws; it is gender-neutral. Even the victim and the punishers both can be male or female, and the laws are same for both. And in 2029, there was an amendment where they increased the penalty, included digital pornography and victim compensation as well. And there 2020, there is an interim rule where the law allows for a passing of an order for interim compensation to meet the immediate needs of the child. So now moving on to the challenges. The jurisprudential challenges are there are low conviction rates and high pendency of the cases. So more than 30 to 35 cases are not convicted properly, and high pending of the cases are also there or also can be seen. Insufficient special courts and lack of trained personnel. So in under POCSO Act, it is very important for the child to have a trained personnel with them, which is like a resource person or a support person for the child. But from the studies, it can be seen that there is a lack of trained personnel for the in India, and inadequate forensic and counseling infrastructure. So forensic labs are overburdened and under resourced. So because of that, what happened? The cases, even if the evidence are there, it takes some time to get that forensic report in time to the court. So because of that, conviction rates again decreases. And stigma and underreporting, especially in terms of intrafamilial cases, because when the perpetrator is from the family itself, it will be very difficult for the child to speak about it openly. And there are misuses in criminalizing consensual adolescent relationships as well, because under POCSO there is no section defining or describing the consensual sexual intercourse between two adolescents. So there are chances of criminalizing these consensual relationships as well. So these are the jurisprudential challenges that can be seen. Now moving on to the psychological dimension. Child sexual abuse can lead to complex trauma, anxiety, depression, and dissociation in children. And because of this, it is very important to have a child-friendly environment in the courtroom. Like a child-friendly language should be used by the judges and the advocates and the police, and rest break have to be there, and female officers has to be in assistance with the child all the time. And there have to be some support person to bridge the gap between the legal and the psychological support. So there have to be someone who can explain the child what is going to happen now and how the procedure will go on, so that the child will be more comfortable in the courtroom. And service gaps. So one thing that we can see is a rural-urban divide that is seen in India, and only few integrated trauma services are there. So when it comes to rural-urban divide, children from urban background or urban setting, it is easier for them to assess the police station or to assess the court as well. But when it comes to rural children, it is very difficult for them to first of all come out to talk about these things, and it is very few resources are there to give the legal advices for the children as well. And there are only very few integrated trauma services like Bharosa Center, which is in Telangana, and Samvad Nimhan's guidelines, which helps there is an integrated multidiscipline integration in law, legal, psychological, and policy ways. But the problem is there is only very few trauma services. So Bharosa centers are only in Telangana, while Samvad and Nimhans, even though they are providing the help in 29 countries and 2 union territories, still the accessibility is very low. When it comes to cultural and intersectional context, the stigma and silence, fear of dishonor, especially in intrafamilial or caste-linked abuse. So, ostracization and fear of dishonor will be there in the children, and even if the children tells about this to any of his or her peers or even mother, they will also feel like, okay, we shouldn't go and report these things because it will be a dishonor to our family. And more than 90% of victims are female, while boys and trans children have high number of underreporting as well. Then studies have also shown that Dalit and tribal survivors face barriers in FIR, reporting the FIRs and prosecution as well. But panchayat, teachers, and NGOs act as a protective allies who can help them with this. But that is also not there in all areas of the country. In rural areas, it's still a difficult task. So, coming on to the summary or the discussion of the review. So, legally, there are strengthened frameworks. The POCSO Acts defines lot of mainly most of the offences and how it is being punished and everything. But the gap comes when there is an inconsistent enforcement in India. So what we can do is a regular judicial monitoring can be done in all the courts in India so that the consistency will be there. And when it comes to institutional domain, there are special courts, e-box. E-box is where it's an online platform where the children can report their own abuse online. So they don't have to go to a police station to report the crime. So special courts is for the speedy trial, and then National Commission for Protection of Children Rights. So these institutions is helping the children in this aspect, but still there are unequal access, as I said. So mandatory intersectoral review has to be done. And when it comes to psychological domain, there is a recognition of trauma. Also recognize the trauma of the children, but there is a service deficit, and even the personnel, there is a problem with the quality and the accessibility of the mental health services that can be given to the children. So integrate trauma informed care will also help in this aspect. And when it comes to socio-cultural domain, there is a greater awareness. Most of the people know what POCSO is, and most of the people know that there is a chance if something happens to the child, there is.
Can you come to the conclusion? 12 minutes is over.
But the gap is stigma and misuse are still there. So, in order to conclude, protection must go beyond prosecution towards healing, dignity, and resilience. POCSO has advanced legal protection, but gaps persist in the implementation and psychological care. Trauma-informed, intersectional, and culturally grounded systems are essential. The next decade should prioritize integration of law and mental health for true child safety. Thank you.
Yeah. Say anyone like to ask questions? It is not a scientific paper, right? It's a review.
It's a narrative review. Yeah. How can a child access like an online portal? It's an online website. It's available, and you can access from laptop, computer, or even phone. And the child, yes, any child can
in age group. The child is can accessible for e-box.
It goes to the officials like the police station directly. The child doesn't have to go directly to the police station to file a complaint. Yes. Okay. E-box. Ma'am, so this is a narrative review so that we will understand how it's been more than a decade since the POCSO has come into practice and we can understand how it has evolved. And as I have explained, in the law there are like that, or even it's a trauma informative law. It is recognizing all the trauma and the psychological dimensions of the children as well, but yet it is not accessible all over the India. So the implication of this study was to understand how much gap there is and how can we or what can we do as a mental health professional in these aspects. Yes, more researches are required.
Yeah.
Thank you, Ms. Nair, for the presentation. Moving ahead, let's welcome our next presenter. I now invite Ms. Sameha Chauhan to present her paper.
Good afternoon, everyone. My name is Sameha, and I am currently pursuing MPhil in Clinical Psychology from Amity Institute of Behavioral Health and Allied Sciences. Today, I will be presenting a case study which outlines how repeated childhood sexual abuse contributed to the later development of sexual obsession within the obsessive compulsive disorder. In this case, trauma did not simply precede the OCD, it shaped the content and the emotional meaning of the obsession. As we all are aware that OCD is characterized by presence of obsessions which are intrusive, unwanted, repetitive thoughts, images or impulses, and compulsions which are mental or behavioral acts that are performed to reduce the distress caused by those obsessions. Now, OCD can be distinguished based on the content of obsessions. And one of the clinical subtypes is sexual obsession OCD, where the content of the intrusion is sexual in nature and is experienced as inappropriate and morally unacceptable, something we often term as ego dystonic, leading to intense shame, guilt, and self doubt. Now, the compulsion in sexual obsession OCD are often covert and may include mental neutralizing or thought rituals, checking or monitoring the body for signs of arousal, and analyzing the why the thought occurred, reassurance seeking, and avoidance of people, places, and media that trigger these thoughts. Now, unlike other OCD presentations where the feared threat is external, such as germs or harm, in sexual obsession OCD, the fear is internal and moral, centered on what the thought means about the person, and which makes this subtype highly hidden and often misdiagnosed as a paraphilia. Now, as you can see on the screen, there are multiple studies that have been conducted, which indicates that early trauma has a significant impact on later OCD presentation. Research indicates that trauma disrupts the emotional regulation system and alters threat processing, which increases vulnerability to intrusive thoughts and obsessive fears. Individuals with sexual, or which is often categorized under forbidden thought OCD, consistently show higher levels of guilt, shame, depressive symptoms, and suicidality. Now, a common key finding across multiple studies have been that when trauma is present, intrusive thoughts are not experienced as random mental events. Rather, the individual interprets them as evidence of their character. For example, this thought means something is wrong with me. Now, this misinterpretation intensifies emotional distress and strengthens the obsessive compulsive cycle. Although OCD is commonly described as content neutral, which means any thought can take the form of obsession, research increasingly show that when trauma is present, the intrusive thought often draws directly from the trauma-related memory network. Thus, from this understanding, trauma context becomes clinically essential in the study and conceptualization of OCD. Now I will be presenting the case. The case involves a 19-year-old female from an urban middle class background who presented with recurrent intrusive sexual thoughts, significant guilt, and increasing emotional and functional impairment. According to her report, she was approximately 2 years ago, she began experiencing repetitive, unwanted, intrusive thoughts involving sexual intimacy with children. These thoughts were typically triggered by visual exposure to children in public spaces and were immediately followed by intense shame, disgust, and moral distress. Now, the intrusions were accompanied by involuntary physiological genital arousal, which persisted until she engaged in masturbation. Over time, both the frequency and complexity of the intrusions escalated, the content expanded from children to include adults, and the obsessions were often triggered by specific body parts such as lips, neck or torso. In an attempt to reduce distress, or as we say, undo the intrusive thoughts, the client began watching adult pornography. She explicitly stated that the pornography was used not for pleasure but to convince herself that she was masturbating in response to an acceptable stimuli. So it became a cognitive neutralizing strategy. Rather than to intrusive thoughts which involved minors, her relatives like her mother, father, and brother, and her friends, and other known individuals. Following masturbation, she engaged in prolonged showering due to feeling dirty or morally contaminated. Three dominant obsessional themes that were identified were sexual harm obsessions, sexual orientation obsessions, and fear of losing control over sexual behavior. Corresponding compulsions included masturbation as a neutralizing act, repeated showering to relieve contamination type guilt, and extensive avoidance of people, places, and media that could trigger the intrusive thought. And there were also other internal or covert acts like self monitoring for signs of arousal and engaging in the why the thought occurred loop. Now, this is the timeline. Developmental history revealed instances of sexual abuse during childhood perpetuated by two older cousins. The first boundary violation occurred around the age of 4, and similar incident continued intermittently between ages 5 and 9. At that stage of the development, she lacked the cognitive and linguistic capacity to understand or label the experiences as abuse. At approximately age 11 to 12, during a school based sexual safety and awareness seminar, she was able to retrospectively recognize those early experiences as sexual abuse. This realization now acted as a psychological trigger. She attempted to disclose the abuse to her mother, but her mother invalidated her experiences. And then she later disclosed this event to her trusted peers. However, instead of receiving support, the disclosure was resulted in invalidation of her experiences and bullying. Now, this created a secondary interpersonal trauma. Around age 16, intrusive sexual thoughts began emerging for the first time. During this time, she began her 11th grade, followed by the development of compulsive behavior, which was primarily compulsive masturbation and avoidance, which developed completely around the age of 17 to 18. Now, by 19, obsessions and compulsions had been frequently distressing and they were causing functional impairment and depressive symptoms accompanied. These were the assessments that were conducted and which corroborate the symptom severity that were reported by the patient during the clinical interview. Now, this case has been conceptualized in 5 sequential phases, integrating the cognitive trauma model, which was proposed by Eller and Clark, and the cognitive behavioral model of OCD proposed by Silverstein. Traumatic experiences lead to formation of maladaptive appraisal and core beliefs such as I am unsafe, I am at fault, and or I am dirty. Now, because the abuse occurred before ages of between the ages of 4 and 9, the client did not have the developmental capacity to understand or process the experience. The trauma memory was stored not as a narrative memory, but as a sensory, emotional, or bodily impression, which is often experienced as primarily as shame or threat. Now, years later, during adolescence, when she experienced intrusive sexual thoughts, the cognitive appraisal was filtered from these memory networks, these pre existing trauma beliefs, and she interpreted these intrusions as this proves something is wrong with me, I am immoral, or maybe I am the pervert. During adolescence, intrusive sexual thoughts emerged, and because the trauma was unresolved, the content of the intrusion mirrored those early experiences. Catastrophical misinterpretation occurred, and these intrusion thoughts were laid as evidence of her character, believing that thoughts meant something about who she was rather than recognizing them as involuntary mental events. Now, this appraisal triggered anxiety, guilt, and fear, leading to compulsions such as uh, disgust. Now, these compulsions provided temporary relief, but in the long run, they reinforced the OCD cycle. Over time, due to repeated failed attempts to control the symptoms, contributed in exhaustion, hopelessness, and eventually the onset of depressive symptomology. Now, to conclude, this case highlights the complexity of sexual obsession, OCD, when it originates in the context of early trauma, demonstrating how traumatic experience becomes the template through which intrusive thoughts are later interpreted. Within this context, we can understand that there is a need for more clinical models and research protocols that explicitly addresses trauma-linked OCD, particularly those when the obsessive content mirrors the traumatic event. Future research should explore structural integrated treatments that can simultaneously target trauma memory processing and OCD symptoms to improve clinical outcome. Thank you. You can take a discussion. No, Mama, I discussed. You already discussed.
Any questions?
So I just had 2 sessions with her, and she was put on antidepressant medication because, as I mentioned, that the severity of her depressive symptomatology was moderate. She was not going to college, not eating, not getting out of bed. So that was taken care of. The treatment is yet to be done. So once she's in a state where she can be receptive to the therapeutic work, I would like to target the depressive symptomology. Uh, she was very resistant while disclosing the experiences as well. Most of the history I got was from her mother regarding the sexual abuse. So that has to be addressed simultaneously that I address OCD. But because there is so much of resistance and the memory is so distressing, I don't want to address it at the beginning because it might impact my rapport formation with her. So I would first target the depressive symptomology, work on the negative beliefs around them, work on her biological functioning, and then move towards targeting the OCD symptoms and the trauma-informed approach on them simultaneously. Yeah, yeah.
Any more questions? Did you follow the ethical procedures for this case?
Yes, sir.
Then you came to know that she has been monitored some sexual abuse. And did you inform to any legal advisors?
Sir, actually, now that she's 19 years old and the abuse occurred when she was 4 years of old, so the matter is already in some legal form.
Let's see that information which you received from the parent of the child, right?
Yeah.
So is the concern, the patient. when you know that they do take any concern that that information clearly message to the government that the legal procedure is there. Because when you are working in a mental health center, when any case comes in the like sexual abuse in the child, it has to be communicated the appropriate way.
So the case has been taken from a private setup where my role directly there is very limited. I have to consult.
It is recorded in the consent form.
Yes, sir.
Is it a private or government or any form? When you see a patient having complaints that she has demonstrated any sexual abuse in the childhood, that has to be recorded and taken consent from the family member, and this is very important because in like maybe after the your session, she goes to another like recently another present like in Telangana there is a Barosa. In this Barosa centers provides the counseling for like all the type of cases. Then they will brought to the notice. Now they will bring your name into the picture. I was consulted so and so the center so and so the consultant was taken given the treatment all these things. Then you are hiding which is supposed to be communicated to the legal. I think it is very near ethical concerns for such therapeutic intervention is mandatory to record and communicate and take any consent. And you have to keep that record all if possible. Okay.
Once I would just like to add
Yes, please.
as for also when we talk about that is a big day. I could read the audience also on this. So since this case is different, I understand that she's 19 already and she doesn't have like much role to play in that case. So CSC happened when the child was 4 years. That's anyways a backdated trauma. But whenever nowadays, if at all you're practicing in a government set up specially, not that in private they're not supposed to, the MLC and the POXO immediately says this as the government of India's authorities and that if at all you come across anything like that, immediately you need to tell to the SHO located towards nearest the police station which is that has to be reported. If at all parents are not willing, but still, as a mental health professional, that is your very much responsibility. If you're not doing that, that means tomorrow, when your signature is there, anything ethically you're not doing a right practice. Anything can be coming on to you and you can be summoned on the same. That when you were aware, why did you not report it?
That is also related to this case that I asked, right?
Yeah, no, not this case, I'm just adding to what sir
already when it comes
yeah.
practice, you also look at the child's thing, like it
Correct.
has to be in service of the child.
Correct.
Not, like the first president was mentioning the gap of
I realize
it's not that direct.
Ma'am, I got a question. Like, if the family is not consenting for recording, then what should we do?
So this answer I would like.
Yes, sir.
So I would like to tell you, like for example, that is like depends on setup also. So not like really immediate first session, but all you want to give them some time, so make them understand, psycho-educate them. That this is something my ethical boundary. And legally I am bound to do so.
Like because there's so much stigma and trauma.
Yes, I understand. And maximum CSA, if you see that is the person like extended family members. So that is where the dilemma actually comes. That is the moral dilemma. It should always be company. But for you as an ethical practitioner and to take care of your license, which you have earned with your heart, soul, blood, and flesh, I would say that you need to take care of that also. So you tell that this is not in my hand, something which is in my hand. This is something you not first session, it's okay, I'm not reporting. But I instant, like as we move around, I will have to take action. That is because something which is legally, I'm bound to do.
And this is talking about minor or adult?
No, the minor.
The minor.
So children less than 18 years. Right. If he is 17 years, 11 days also, 29 days also, you will still have to report. You remember Nirbhaya case which happened in Delhi 2000, I don't know, 10 child, I think 2010. So if you remember, the one minor was the 17-year-old. And there was a lot of debate happening around. So there was like the Supreme Court also did not after this POXO came into picture and a lot of progression have been made.
Sir, I have a question. So, because it's such a ethical and sensitive center situation, in certain instances, there are reports of false memory, especially when you're retrospectively recalling things. And it might, because she was 19, she was an adult, but in some instances, even after becoming adolescent, there is a false retrospective narration of certain incidents. So, in that case, before we report, how do we verify the validation of the
See, this is actually before concluding of your sessions. For example, the case has come now. Case is working on. Each and everything should record it. My question is, being a professional clinical psychologist should maintain consent and record such cases, especially when you are data writing. The history says that she is having sexual mutation XYZ. You should maintain record. Then, how long when she became an adult? See, when she became an adult, she gives any no fast information. Now the major focusing on your treatment and the symptoms, not the retrospective. See, but your case is a trauma. Trauma persists OCD, right? There you have to working on the trauma eradication. Then you have to focus on the trauma. What is the trauma? Sexual abuse. Sexual abuse been accepted by the client and the informed, like who's the mother. Then such cases is recorded. You are recorded. See, tomorrow maybe they disappear after 10 sessions. After 1 year or later, they're approaching another consultations. They brought to the notice to SHO. Then SHO is recorded the history. Then the SHO says that previously we were consulted amity and then we have taken treatment and what is that, they mention all these things. Then they will be summon you to for the witness, and there is another offense. Why you are professional and you are ethically concerned that bounded for to intimate SHO when you came to know this is the when how long is the minor. That's what my cautious that any clinical psychologist working in private or government. Yeah, see, there is no private government differentiation in the law. When you recognize CRR number, you are bound for to follow the ethics. See why it has happened in 2009 in Hyderabad High Court. He was later he was a Supreme Court Chief Justice N.V. Ramana. He called me for the investigation of one case, and he spent more than 45 minutes to listen our presentation of history and conclusion of opinion. It's not given any report. Conclusion of opinion. He said, "Doctor, is just right and give me the signature." That's more than enough. Means that your signatures are more than valued. That's only my concerns. Okay. Good present.
Sir, I have one more question.
Yes.
It comes like if SSM will ask you like why you are like interfering the others.
No. See, they don't have anything to ask you questions because you are a professional clinical psychologist registered by RCI. RCS give you are eligible to give any witness, legal witness to Supreme Court of India. They don't have any question to ask why you are interfering in. See, I'm a clinical psychologist registered by RCI. I have a role to follow the ethics. And as the ethics says, the Pox Act says that I have to report you. Whether you take, that's your choice. That they cannot question you.
Samia, I think it's
Good presentation.
Thank you, Ms. Samina. Please now proceed to our next presenter. Our next presenter is Mr. Desti Sani, but I don't think he is present here. So we will move forward to our last presenter. I now invite Ms. Khushi Sharma to present her paper.
Good afternoon. Good afternoon, everyone. My name is Khushi Sharma, MPhil Clinical Psychology trainee at Aadhar Soda. Am I audible? So the presentation will covering the following points: a comprehensive clinical profile of a young woman with dissociative convulsions in a moderate depressive episode, to further explore the interplay between compliance and internal conflict in patient's personality, family dynamics, and socio-cultural background contributing to the symptom formation, and to understand a case-based formulation which will facilitate us in the intervention planning. So dissociative episodes are closely linked to an emotional dysregulation, early life trauma, and ongoing socio-cultural stressors that we all know about. They often emerge as a coping responses to overwhelming emotions that that the individual is unable to express openly. So, in a rigid or in a patriarchal family, and in a rigid and a patriarchal system, expectations of obedience and conformity can further lead to emotional suppression, which further increases the vulnerability to dissociative symptoms. These episodes can frequently reflect an underlying interpersonal strain and role of conflict, functioning as expressions of distress rather than purely psychological illness. There's a frequent presence of comorbid depression and anxiety, which suggests that there's a significant internalized stress and persistent difficulties in regulating emotions. The literature suggests that dissociative episodes are complex responses to often emotional conflict and social-cultural pressure. In young women, particularly within collectivistic societies, dissociation often reflects the tension between fulfilling expected social roles and asserting a personal identity. Emotional suppression, trauma, and gender-based expectations have often been shown to heighten vulnerability to such presentation. Hence, the current study will try to focus on the psychosocial and the cultural influences which will address the inner struggle between compliance and autonomy of a young individual. So this is the demographic profile. Index patient is a 25-year-old female. She's a software engineer living in a nuclear family from a Hindu background. Going to her significant life events, in October 2023, she started her job in software engineering, where there was a lot of criticism from her father's side. There was a constant comparison because of the low pay. So this began to impact her confidence, and she used to feel very inadequate about it. Then around December 2023 to April 2025, she developed a close relationship at work with a colleague. Eventually, few months later, that relationship broke off, which further affected her confidence and work difficulties. During July to September 2024, there was continued family pressure regarding the marriage. The father had decided a groom for her and was constantly pressurizing her for marriage. There was also rejection at job. There was increased stress, and this led to the feelings of hopelessness. By January 2025, in a family event, she had witnessed that her father hitting her mother. That is when her first episode of unresponsiveness, which lasted for around 30 minutes, was triggered. There was rigidity, there was no movement, but her hands were clenched for a period of 30 minutes. She was taken to a nearby hospital where her medical reports came out to be normal or her neurological findings. Around April 2025, there was another episode of unresponsiveness at workplace during stress, and eventually a stress-related diagnosis was suggested, and that there is no neurologically something to be concerned about. Around June to July 2025, due to these ongoing difficulties at work, due to her father's constant criticism about work, the patient began to develop persistent low mood, fatigue, poor concentration, sleep disturbances, and social withdrawal, which was the reason why she was brought to the psychiatric setup. If we talk about her family history and family dynamics, so her father is 51 years old, who shares a hostile relationship with a mother, who's a housewife. Father also shares a hostile relationship with the patient as well. So the overall, the family acknowledges patient's symptoms, but they tend to attribute these to stress or emotional weakness rather to a psychological condition. The father views and manage. The father asks her to manage it with willpower, and rather than seeing it as a condition. Her mother is somewhat supportive, but when it comes to the father's decision, she usually complies to him. When we talk about her siblings, so her brother recognizes that there are changes in her behavior, and he was the one who was also somewhat encouraging her to seek help. If we talk about patient's pre-morbid personality, overall, it suggests that the patient was usually a responsible individual who used to seek a lot of reassurance and approval from others. Uh, she shares a cordial relationship with her peers, but shares a distant relationship with the family due to the reasons which were mentioned. She appears to be non-assertive and avoids confrontation, often relying on others for major decisions. Although she engages in leisure activities, she tends to worry easily and experiences anxiety when there's an increase in burden or responsibility. She's described herself as quiet and adaptable, preferring close and stable relationships. Overall, these findings suggest a cluster C personality trait. So I've conceptualized the case using a cognitive model of psychogenic non-epileptic seizures by Ruber and Rawlings. So this model basically conceptualizes dissociative convulsions that they occur when there's a heightened threat perception, this chronic stress, and there's an impaired emotional regulation, which interact and creates a seizure scaffold. In the present case, there are multiple cues such as father's criticism. These are external cues. Like father's criticism, there's constant comparison with the cousin. There is oppression from the family regarding marriage. There was also disappointment from the workplace at the job. There are certain internal cues such as guilt, fear of failure, low self worth, which are contributing to the persistent sense of threat and emotional vulnerability. These repeated stressors have led to a high physiological arousal with frequent experience of anxiety, crying, emotional tension. Prolonged experience to these stressors have resulted in a state of chronic hyperarousal and exhaustion, where she found it increasingly difficult to express or manage her emotions. Over time, this pattern of emotional suppression has caused an inhibitory processing dysfunction, which means that there's a weakening of her ability to regulate, affect, or control her bodily responses during stress. Given her personality vulnerability also, which is characterized by high harm avoidance and a low persistence, and dependency on external validation, her brain has gradually formed a seizure scaffold, which is a learned dissociative response to overwhelming emotional conditions. This scaffold was activating during intense stress, which was here the father hitting the mother, and also criticism from the job. Uh, and these stressors had exceeded or overloaded her capacity for regulation. Consequently, due to this, she experienced a psychogenic non-epileptic seizures, which manifested as unresponsiveness, rigidity, and reflecting a conversion of intolerable emotional arousal in dissociative physical state. Further, I've also used the CBT model of depression. In this case, the patient grew up in a restrictive and a critical family environment where the emotional expression was limited. Her father was dismissive and had a competitive attitude. Her mother's tendency was to minimize her concerns. Uh, Further, as she grew older, her beliefs evolved into dysfunctional assumptions, which were I must meet others' expectations to be valued. Consequently, her self esteem became dependent on external validation from the family and others. When she encountered critical life events such as dissatisfaction with the job and salary and repeated comparison with her other family members, also there was a significant termination of a long term relationship. All these factors activated her underlying core beliefs and assumptions. This activation resulted in a negative automatic thoughts like I am a failure, nothing that I do works out, which reinforced her sense of hopelessness and inadequacy. And over time, these maladaptive thoughts and patterns had led to depressive symptoms. So when we talk about the assessment findings on TCI, there was a low on novelty seeking, which reflected that she had a slow tempered, reserved nature, while high on harm avoidance indicated anxiety, fearfulness, and pessimism. Low persistence and self-directedness suggested inactivity, difficulty in goal setting, whereas low self-transcendence denoted impatience and a sense of unfulfillment. The findings of thematic perception test further revealed themes of helplessness, isolation, fear of failure in meeting relational and societal expectations. Her parental figures appeared harsh and punitive, and dominant needs included autonomy, affiliation, succor, abasement, reflecting a conflict between a dependence and an independence. Outcome. So outcome indicated significant clinical and functional improvement over a span of 40 days. On the multidimensional inventory of dissociation, her score reduced from 21, which represented a moderate dissociative symptomatology, to 9, which is in the non-clinical range. On Beck depression inventory, her score was earlier in the moderate range, which is now after sessions is in a mild range. Overall, when we talk about functional outcome, there's an enhanced stress tolerance and coping with emotional triggers, improved occupational functioning and daily routine stability, increased self-confidence and independent decision making, and better interpersonal communication and family adjustment. Further areas of management which are to be included are to rebuild her vocational confidence and goal clarity, to strengthen her emotional resilience, and to build a long-term relapse prevention strategy. So the intervention was basically structured across 5 phases to ensure that there's a gradual stabilization, psychoeducation, emotional awareness and cognitive restructuring, interpersonal role and functioning to improve communication assertiveness, and relapse prevention and future planning. Implications in cultural context, so it plays a very crucial role in how emotions are expressed and how symptoms are manifested. In a collectivistic setting, distress is communicated through physical or dissociative symptoms rather than verbalizing it. Early maladaptive beliefs such as I must please others to be valued, they further reinforce emotional suppression and heightened vulnerability to stress and dissociation. Interpersonal conflicts between autonomy and compliance create an internal tension where attempts to assert independence trigger guilt and anxiety. So, this case illustrates how some psychological distress emerges at the intersection of an individual's needs as well as socio-cultural expectations. Thank you.
Any questions? Only 4 audience. No, organizers also audience. You can have questions, you can ask. No questions? Why did you use TCI? Why did you use TCI, temperamental characteristics inventory?
Wanted to assess her temperament also, and TCI is very helpful when we are planning an intervention plan also. So her pre-morbid personality has also suggested that she was low on assertiveness, she was low on confidence. So for that, to assess her temperament also, I had used this.
See, what is the precipitating factor for having problem?
Her precipitating factor was getting a job which was below her expectations, also followed by father's criticism that she should get married, she should not take up such a low paying job, her cousin is doing well. So these were the main precipitating factors.
Is not the breaking the relationship?
That came in the following months, which was one of the factors.
Did you quantify that emotions his father, her father may be consistently criticizing her performance, right? Since
child.
Then how can it's is the precipitating factor now?
Nature has been like that since childhood, but when she got the job, Her father assertively told her that you should not be taking the job, and the father stopped talking to her. So father actually began disapproving her decision.
Now you are talking about the father constant criticism towards the child since childhood. The precipitating factor,
The precipitating factor was getting a job that was below her expectations, which triggered feelings of inadequacy in her, followed by father's reaction that you should not be taking this job. Your cousin is doing much well than you, and
comparison.
comparison.
See, now father is very commonly criticizing since so many years. See, maybe you are hear the same thing, the comments from the parent since childhood. So you adapted, right? Now, where is the another important comparison? See, when she became a employer, when she start working it, where the father criticized and compared and then humiliated. See, that could be the reason. Or otherwise, any other reasons are there?
Sir, primarily at the same point of time, around October 2020, multiple things happened. It was her first job in life, so that is why that was a very stressful time for her. She went to her family for some kind of approval. She needed some confidence in her, which her family failed to give in her. So that further elevated the stress. At the same time, she also had some expectations from herself that I wanted to have a package, a certain package which she failed to get, but then she needed a job to be independent, so she took that job. So even though she was going to work, but she was not very happy about it, so it further triggered feelings of inadequacy. Her temperament has been of a person who has been very underconfident, so her personality wise also she was challenged on the work also, because that at work she was required to be on stage to give presentations, to be very active around. So that was the time. There were constant stresses also, but this main time is when the main concern started.
Means that she is like she got a job where she is getting into the job, and all the stressor has a precipitating factor to acquiring of emotional disturbances. Because there's a lot of things are there. See, our expectations are packaged. See, as the first time she's joining into the employment, now she wants approval from the family members. She has at a stretch so many things. The whole, it's everything is around surrounded by the employment. She's joining in the job. She's joining into the job. Joining into the job is a precipitating factor. See, father's criticism is exists from childhood. Maybe here also there may be like no something more comparison with other cousins and XYZ. Then like TCA is clear, right? So it's good because why did I ask you TCA, right? Why don't you use another no test? See now, so how old she is?
25.
25 years. You chosen TCA. Now whether you wanted to see the temperamental or personality.
Sir, I wanted to see her temperament also, because
Why?
that would have an impact on our therapy plan also. But in this age, I understand that we focus more on personality factors. Uh, there were some cluster C traits, but they were not on a very clinical level.
Then here is the traits. When you mention the traits, now you are before the traits. You know the construction of the personality. There is a characteristics, habits of the characteristics, then the temperaments and traits. Then the different traits become a personality type. Is it right? Now you are supposed to assess the personality, and you can see the personality profile. The personality profile will give you all the temperaments. If you should have profiled a personality, and you can write all these things inside the personality. See, I'm not criticizing you. I'm just trying to explain you in the future. Think those who are crossing of 18 years and above, understanding of personality profiles rather than going to temperamental aspect. For understanding the within the temperaments, what are the temperaments are deviated, what are the temperaments are within the normal limit, what are the temperaments are below cutoff score. You can see for understanding. But presentation, you need a profile. That's also very important. And also how you are using for CPT for this case. And what technique you are going to use for to see changing in the temperaments.
So I would like to ask you, you've talked about one model, PNS, which is a very latest model. Like I think it's been given around 2018. Yeah. So were you able to justify the seizures classification into with the model?
Yes, ma'am.
Did you get enough evidence? Mm.
There were external cues also, external
Right.
stressors, there were
Right.
internal cues also. Her ability to manage and regulate her stress was also impacted. All of that became very repressed and they came out in the form of dissociative convulsions. This is why I had used the.
So how many sessions did you take with the patient?
Ma'am, I've had 5 sessions with her now.
Okay. So I think that's a very good thing. I'm very happy to see the model that you used because you've talked about the depressive thing, depressive clinical complaints with the CBT. That's how you formulated. And only for dissociative, this thing you've talked about PNAs. So that's a very good thing. I congratulate for you for that. Also, along with that, I think if you ask me, like if I would have been at your place, I would have taken 4P model which actually goes very well and blends with your case very nicely because if you see the psychopathology's beginning, this is from very beginning, like if you talked about cluster C, you talked about other issues with the family members. So I think then if you talk about maintaining factors, predisposing, maintaining, perpetuating, everything is there. So 4P models actually explains your psychopathology much easierly and much betterly as compared to, obviously this is what you've taken is for the conceptualization for the treatment purview. 100% agree. But if you take with me, like you can take one consideration of this also. You can try and formulate and you will get what sir was asking. No, why did you do cluster and why did you not do personality? That will be able to answer what it is. Right? Okay, thank you so much. Good presentation.
Thank you, Ms. Kushi Sharma. Will that be come to the end of the paper presentation for this session?
I would like to express our heartfelt gratitude to our respected chairperson, Dr. Vinket and Dr. Nishtha Kumar ma'am for their time, guidance and insightful feedback. A sincere thank you to all our presenters for their hard work and valuable contributions and to audience for their attention. I now request Dr. Deepika Srivastava ma'am to please felicitate our chairperson. Sir. Ma'am, Nishtha ma'am. Thank you so much, all of you.
You three papers are very good, but we need to work more. But what is your paper is like review paper. We need to address to the government. Now government is working for modification in the POCSO Act. Okay, and Disability Act also. Recently there are the modification, in the Disability Act in 2020. Presenter. All the presenters. But you have to work hard. I understand. I'm lucky sharing your perspective.
Yes.
Other trainees of I have some
Thank you.
there are other trainees also.
Yeah, okay,
All of them.
This guy.
Volunteers can also join it. You can just you can come. आ जाओ पहले आ जाओ देखते हो तो चलेंगे अब तो आएगा ना हाँ प्लीज Thank you.
Thank you.
You just get the certificate so that we can provide them the certificate we will get it. Ma'am, I want your paper law. Yeah, please come. Who has gone to collect the certificate now?
I will get here. That's better. Yeah, that's better.
Thank you. Thank you. Thank you.
Your product is very.
Sir, I have done my GDC. I'm from GDCH, Chandigarh.
Chandigarh.
And my PhD is from Dilpas.
Oh.
That's it. Yes. Dr. Mulranjan, Dr. Moshu. Yeah, sir is my guide.
I am from Kibanaras. I did my MPhil from Kibanaras and PhD from DA. When I was when I first I did PhD with 2012.
Yeah. 2005.
Oh, अच्छा. All right.
We have proper workshop.
All right.
This was you must have no training.
She joined at that. Now she is there. Dr. Ruba Sharma and her party now.
We expect always from similar level. There is level. I did not go to 9 staying in Hyderabad.
So, madam, we can call them.
You call them. They come. Please deny.
So, we have marker, we can write them. We have to marker to write them. आप लोग marker later.
You can write it. Questions okay. You can write yours.
He will write now.
Can we request Ms. Table to come?
All three is time.
Yeah.
अच्छा आप लोग मुझे
It's okay. You can join us now.
You can keep this one. Okay, take it. You are from?
Can we request Ms. Samiha Chauhan to come?
You related two aspects, FOCSO and therapies and so on.
It's okay, sir. It's okay.
Lastly, can we request Ms. Khushi to come?
all of them are very sincere.
Yes, that's good. That's sincerity.
Yeah.
So maybe we put less.
So good work. All the
That's only to encouraging you.
Very good.
No great. Okay.
Grow up with whatever learning you're doing. हाँ मैं इसको डाल देती हूँ एक सेकंड हाँ मेरे को भी एक सेकंड दिखा दे Which one is absent?
Second question. Third is absent. Who was the second person? Isha. Who was the representative?
First कौन था? करुणा. Fourth कौन था? ईशा.
समीहा.
ईशा fourth कौन था? Fourth presenter.
समीहा.
अरे third नहीं है मुझे.
Good team.
Every single day. नहीं सबका अच्छा था, was good. Sameem has got the best paper. ये पेन तुमने दिया था मुझे? पानी डाल दूंगा सॉल्यूशन. मेरी छोटी पिक्चर पहले तो जल्दी से जल्दी से जल्दी से. नहीं अच्छा था. दीपिका मैम एक सेकंड आओ. कोई नहीं चलेगा चलेगा इतना मत सोच. वो सब पहले करूंगा. हाँ मेरी
नाम लिख दो सब लोग सर्टिफिकेट से होगा.
हाँ मैम.
मुझे ये बोला.
अच्छी मैम. नहीं अच्छी. ये वाली हैवी साड़ी तो ऐसे
Autism spectrum disorder is characterized by social and communication deficits along with restricted and repetitive behavior. It varies by age, adaptation level, and the ability of language. So let me enlighten you on it. धीरे धीरे बोलना तो नहीं
Summarize करना आ जाए टाइम नॉट ये चाहिए क्लास सेशन नहीं बताओ हाथ डॉक्यूमेंट को बताओ ये तुम्हारा आंसर डॉक्यूमेंट है मतलब ये हटाओ ये हो गया ये तो पूरा बना देता है लिखा तो हुआ नहीं बस और भी नहीं क्या ये ऑडियो ऑफ है ना
मैम वो आई थी यहाँ पे, उसने हमारा भी बीच में अटेंड किया, अभी वो लोग सभी लंच कर रहे हैं। आपने लंच कर लिया? तुम कर लो, कर लिया? यहाँ पे कोई है? यहाँ पे है ना पेपर प्रेजेंटेशन? स्क्रीन पे है ना पहले? देखना कॉम्बिनेशन 13 है। हाँ, सेशन 13 है। हाँ, हम लोग बैठे हैं। हाँ, हिंदी का कम हो। Happy very good. Call them na. The team you want to hostel also na? Yeah, yeah. Himani and God. Very good. Himani Karnavati. Subhanji Sharma. Subhanji Sharma. Sarah, put the call for Subhanji Sharma. Ask her to come here actually now mall. So the paper presentation commence. It commences. Is Takreem Malik here? Am I pronouncing your name correctly? It's Takreem Malik. Okay. Sahil is here. Shrija is here. Himani and Shubhangi. Shubhangi Sharma. Samina, please bring a minute note.
Very good afternoon, everyone. I warmly welcome you all to the scientific paper presentation as part of our conference. It is my absolute honor to introduce the esteemed chairperson for this session, Dr. Tarana Jain, Assistant Professor of Amity Institute of Behavioral Health and Allied Sciences. We will begin with the presentation. Our first presenter is Takreem Malik. I now invite Takreem Malik to come and take over the presentation. Thank you so much. Am I audible clearly? Uh, Good afternoon, everyone. My study that I'm presenting today is a gender-based differential item functioning study on Corner's 3 parent rating scale of ADHD. I am Takreem Malik and I am associated with the Department of Clinical Psychology at SRCC, Center for Child Development, Mumbai. Attention deficit hyperactivity disorder is a clinically heterogeneous and a complex neurodevelopmental disorder with a worldwide prevalence of over 8% in children and adolescents. Research estimates that this ADHD as a condition is one of the biggest contributors to the global burden of childhood disorders, increasing the economic burden of raising a child with ADHD over 5 times than raising a neurotypical child. Now, over the years, researchers have questioned the validity of applying a universal diagnostic criterion to for ADHD diagnosis, noting that there are significant cultural differences in how symptoms are perceived, conceptualized, as well as managed. While some attribute these differences to simply methodological factors, there is growing evidence in terms of suggesting that the ADHD is possibly biologically rooted and may also, other than biologically rooted, also may be viewed as a social construct, with symptom expression and interpretation thereby being very context driven and differing across cultures. Now, this issue is something that extends beyond the diagnostic process itself, which largely relies on parent report of child behavior. Although these reports of parents about the child behavior is quite valuable, they often are of quite subjective in nature. They often reflect the culture rather than the true symptomatology of the child. Now, cultural expectation therefore will contribute to gender bias in diagnosis as well. Girls, there is consistent research which suggests that girls are frequently under-identified because of their symptom presentation being much more socially appropriate, aligning with socially appropriate behavior, and tends to be much more internalized in nature. Now, studies also further show that informant ratings are shaped not only by the child's characteristics, whether it's a boy or a girl or other age related characteristics, but also those of the informant, where mothers, for example, tend to rate boys much higher for externalizing symptoms as compared to fathers rating the same child, and girls lower on the internalizing ones. Now, these patterns raise quite important questions about the validity of parent report scales and how these gendered expectations may shape our understanding of ADHD. It's possible that parents may ascribe different level of symptom severity based on the child's gender, despite having similar severity in both genders. Now, the present study examined gender-based differential item functioning on corners 3 using an item response theory framework. The goal was to determine if gender is something that is specific, is creating a bias about whether ADHD behaviors are rated differently across genders with similar severity. Now, data was drawn from a sample of about 210 children diagnosed with ADHD at a rehabilitation unit of a tertiary care center. The sample included little more boys than girls, however, they were ranging from early childhood through adolescence. Now, analysis was conducted on DSM 5 scales of Corners 3 parent rating scales of ADHD specifically, and analysis was done using differential item functioning using an IRT framework for logistic ordinal models. Now, the mean age of the sample here was found to be 10.6 or 10.8, and approximately 64% of the sample of the pediatric age group were children who attended mainstream schooling. Now, all items on the ADHD scales in terms of the item analysis and item level variation did show adequate response variability, so there was no skewness in variability of response, suggesting that parents used full range of responses here. Now, results from the differential item functioning reveal that none of the items were actually flagged under the formal chi-square criterion,
There were two criterion used, one for formal chi-square criterion, and there was an informal raw criterion also based on non-statistic significant gender-related bias. However, so this overall suggests that there were no bias in terms of parents rating for ADHD on girls and boys, at least for this sample. However, one item which is easily distracted by sight or sound on the corners 3 rating scale did show a small signal under the raw criterion. However, the effect was extremely minor, so this should be understood with the fact that this was not found to be clinically significant here, statistically significant. However, the trend of, if you see the predicted probabilities, what you see is that there were higher probabilities for lower response category for girls. That means despite the fact that they were showing internalizing symptoms, they were showing lower response categories here, and much higher probabilities for higher response categories. And that suggests that distractibility, although present similarly in girls and boys, may be when present similarly, may be perceived little less when it comes to girls. Now, the results of this study, while reassuring with respect to the validity of Corners 3 scale, must be viewed under the broader context. Now, across several large-scale studies, findings generally support gender equivalence in parent. Analysis based on item response theory, however, are quite few and tend to show that there are some scales which show equivalent functioning for boys and girls. However, more recent works using updated DSM-5 scales show some gender-linked patterns wherein parents often endorse greater number of hyperactive behaviors for boys, for example, fidgeting and excessive movement, and this tends to be quite over-reported than actual clinical presentation. And verbally and socially oriented behaviors, for example, excessive talking, interrupting others, is much more frequently associated with girls, even with similar severity between girls and boys. Now, this suggests, and actually these findings are found across informants. These, even in teacher ratings and parent ratings, these findings are quite consistently seen. Now, these findings, especially of the studies that do not show any gender bias here, tend to raise important questions. Is it possible that do children with ADHD in India truly show no gender-based variation in symptom expression? Now, this seems very unlikely. As clinicians, we have seen girls showing quite a lot of internalizing symptoms, which is much more socially appropriate and accepted, which is also the reason in India also girls tend to show low diagnosis rate as compared to boys. Now, in terms of the study specifically, it's possible that the data collection method may have influenced our results. Now, these parent ratings, more importantly, was collected in a hospital-based tertiary center where assessors often had to read the items aloud to the parent because of the difficulty in understanding some sentences, even though their language was first, English was the first language in many cases. Now, this may have unintentionally converted a structured parent rating scale into a questionnaire of a semi-clinical interview format with often tone and clarification shifting the understanding of items, thereby masking gender patterns that are often seen in other international studies. Now, while this study had limitations of being specifically for a hospital referred sample and a modest sample size of 210 patients, it provides insights about how parents are perceiving and ADHD and how administration processes can mask gender patterns which are seen globally. So, for researchers, these findings highlight that it is firstly very important for us to examine all international used tests in terms of Indian context, understanding how they function differently across cultures, contexts, gender, and administration format. And therefore, future work should explore whether interview style administrative processes may be better for parent rating as compared to parent rating because it might reduce the gender bias that may not reflect through symptomatology. Thank you.
Questions? Your result mentioned that hyperactivity and distractibility was greater in boys and girls.
This is consistent research, yeah.
Is that the result of?
So the results was trying to find if there is a difference in the way parents report similar severity symptoms differently for boys and girls. So, for example, if there are two children with
same exact severity of ADHD inattention, will the boy get higher rating of inattention as compared to the girl? The results in this sample specifically did not find any specific significance. There was one item for excessive talking, which was rated higher for girls in attentive symptoms, but for boys that was not something that was seen. So again, it is in line. The insignificant one also is in line with the existing research, which says that girls tend to respond, get lower probabilities of response, so they tend to go under-identified and under-diagnosed. Yeah, thank you. Next.
Thank you for the presentation. Moving ahead, let's welcome our next presenter. I now invite Mr. Sahil Kanet to present his paper.
Hello, am I audible? Good afternoon, ma'am. Good afternoon, everybody. My name is Sahil Kanet. I'm an MPhil second year trainee and here to present my paper on application of the verbal behavior approach in children with autism spectrum disorder. It is a case series. So autism spectrum disorder is characterized by social and communication deficits along with restricted and repetitive behavior. The presentation varies by age, adaptive level, and the level of language. In India, the prevalence of autism spectrum disorder is around 1.12%, and the major deficit seen in the disorder is in the area of language. Now, to understand language, we have to go back to Skinner, according to whom language is learned behavior shaped by the environmental reinforcements. So, the idea that words lead to meaning by their function and not by the form of these words. The basic principle is that language use leads to reinforcement, and the reinforcement then leads to self-sustaining and adaptive use of language ahead. Now, for the intervention part, the gold standard treatment for autism spectrum disorder is applied behavioral analysis. This has been known for several years. These are some of the recent studies. In the Indian context, we have also moved forward. We also have a study that used an app-based program for applied behavioral analysis. Now, the verbal behavior approach is a subset of applied behavior analysis. The idea was based on the model of Skinner and was operationalized by Barbara in her 2007 book on verbal behavior model for children with autism spectrum disorder. The idea is to use motivation and reinforcement to develop the use of language. So now there are four basic operands. The first one being mands, which is where the child learns to request to fulfill a need or desire. The other one is tact or tacting, which is labeling or naming things in the environment. The next one is echoic, where the child learns to repeat or imitate the spoken words. And the last one being intraverbal, where child learns to respond verbally to another's verbal statement or question. Uh, Now, research shows that verbal behavior approach has superior outcomes compared to standard ABA protocols in the domains of language use, social, behavioral, and the use of spontaneous communication and language. Some of the specific studies for MANDS, say, listed out here a few studies that can conclude that it leads to acquisition and generalization of requests in a better way than other interventions. In tacting, it leads to spontaneous labeling in children with autism spectrum disorder, and echoic and intraverbal training helps to develop higher order verbal repertoires. The aim of the study was to assess the effectiveness, qualitative impact, and the feasibility of verbal behavior intervention for enhancing communication and adaptive functioning in children with autism spectrum disorder within the Indian clinical outpatient setting. Uh, the the research gap in the study was that there is strong international evidence for the use of verbal behavior approach, but there are not many studies in the South Asian context. Only one study from Pakistan by Khan and Iqbal, which was published in 2022. Uh, Apart from that, we also know that there is a very less number of mental health professionals in India, including clinical and rehabilitation psychologists, about 3,500 to 4,000. And the burden of the disease is at 1%. That is a very large number for a population of our country. So we need to move towards models that are parent mediated, where rather than doing 40-hour long interventions with children, which is not possible in our context due to lack of resources, we need to teach the parents to do the intervention rather than putting it on the clinician. The study is a quasi-experimental single-group pre-post study of 4 children aged 4 years to 6 years. They were diagnosed with autism spectrum disorder as per ICD-11 by RCI registered professionals. All of them were presenting with marked communication delay and limited verbal repertoires. It was conducted at NIPID Regional Center in Noida, which is a multidisciplinary government facility for developmental disabilities. It was a one-to-one therapy session with child and parent. The sessions were delivered by an MPhil clinical psychology trainee under the supervision of RCI licensed clinical and rehabilitation psychologists. The assessment tools used were the primary one was Autism Indian Scale for Assessment of Autism, that is ISA. Other tools were behavior assessment form and skill tracking sheets that were adapted from the 2007 book by Barbara, and also parent report and therapy session records. The intervention framework was there. It was currently what we presented in the study is 8 weeks of intervention, though the intervention is still continuing. 45 to 60 minutes of each session. Some of the things we used were discrete trial training, breaking it up into small pieces to teach the child, natural environment training, and using individual reinforcers. And we use prompting and fading to teach the ecoics, mands, and tags to the child. As I mentioned, the inclusion criteria. The exclusion criteria was severe sensory or motor impairments or major medical comorbidities. These are the profiles of the children. As you can see, as you can see, all of them have mild autism spectrum disorder, along with mild to borderline level of intellectual and adaptive functioning. Two of them have comorbid attention deficit hyperactivity disorder as well. Uh, Most of them have single to double word utterances and delayed milestones, along with echolalia and reduced use of receptive language. Now, after the intervention, if we come to this slide, we are able to see that there was a reduction of about 6 to 9 in the score of ISA, though all of them are still at the level of mild autism spectrum disorder. In terms of listener response, which was about 40 to 50% for all of these, it is now at about 80 to 85% for all the 4 participants in the study. We were able, so the intraverbal response was very less in the participants. We were able to do some form of work with them on that level, and teaching mands and tags was still very well, and along with ecoics. Domains that showed the greatest change were speech, language, and communication, along with social relationship and reciprocity, and emotional responsiveness. There was also minimal change in the behavioral patterns. Moving ahead, we also saw in the parent feedback and observation from the therapist's notes, we were able to conclude that the parents reported clear reduction in tantrum episodes. Children showed better cooperation during their daily routines, such as dressing, meal, and play. The parent observed an increased use of words and short phrases, more spontaneous request, and clearer intent behind the speech. There was shared play, more interest in engaging with siblings and peers, and the children were more expressive, used more gestures and vocalization. Now, this might seem like a lot has happened, but this is like the amalgamation of all the things we could see. Uh, because it was a parent mediated program, we have results, but it was only 8 weeks. So you should go by this slide, the qualitative results more, where we have some level of improvement, but not as much as you would expect. And the reason for that is that it is not an intensive 40-hour therapy as it's done in the Western countries. It is parent mediated, so it is more accessible to the people in a setting like ours. Now, to conclude, we had consistent gains and we observed better communication, attention, and compliance following the 8 week verbal intervention behavior. It targeted the core deficits in language, social reciprocity using the MANS, TACTS, ecoics, and intraverbal training. One of the main things that it addressed was that it was a parent mediated intervention. And so the lack of mental health professionals in this country and the increased burden of disease of autism spectrum disorder, uh, we will not, if we do individualized therapy or 40 hours of intensive therapy for each child with ASD, we would not be able to address all the children. If we teach the parents, do a good psychoeducation, and we do good parent management training, we would be able to teach the parent how to manage the child and then supervise the parent, making interventions more accessible. Another drawback you could say was that it was implemented alongside other modalities. So other rather than the behavioral approach, we also were using other methods of uh, applied behavioral analysis to tackle other issues that the parents reported. Uh, you have to also look at the fact that the participants also received multidisciplinary care, including occupational therapy and special education. So we cannot say that the improvement was specifically because of the verbal behavior approach, but this is a initial study because we don't have any studies in the Indian context as of now. The sample size was small and the duration was short, only 8 weeks, and we cannot generalize the findings in the study. The future studies need to be done with large controlled samples, extended duration, and standardized tools to isolate the effect of the verbal behavior approach. The clinical implication is that this can effectively strengthen functional communication and parent mediated generalization in autism spectrum disorder and make intervention accessible even for the people in our culture because of the large population that we have. Yeah, these are my references. Thank you so much. Yeah.
So, for verbal based learning, this is very nice that you have put up a very good intervention method. What I wanted to know is what level of language the child needs to have to involve themselves in this
So
verbal.
a lot of children are not able to speak.
Yeah, because most
then
of them are non-verbal, right?
During my clinical training at Tepid, you need to send them for speech therapy. The speech therapy will still continue anyway, but if the child is able to converse in single words, right? If he's able to use single words, then we can work on this approach. But also in the book, it also mentions that even if the child is non-verbal, there is another approach where you can use gestures to teach the child. Because the idea is that what we call problem behavior, escape, attention, something tangible, or something sensory. That these are the four categories which you can put so-called problem behavior into for children with autism spectrum disorder. All these happen mainly because of either the reinforcement is too low or the difficulty is too high, or the child is not able to express himself or herself. So the idea is to teach communication in some form. Here it is in the verbal behavior form, but also with use of signs and all. And once the child starts using that, he gets what he wants, that is reinforced, and the use of those signs, or in this case, verbal behavior, leads to just use of that language.
So, how is this program different from ABA or NDBI?
So this program is not
Because
different.
they also have the same reward systems.
It's part of ABA intervention. It is a subset of ABA, but it is not generally used in the settings because, for example, where I am in NIPID, verbal behavior approach is not being used. I've talked to other places also; they're not using.
No, we are using MAND quite often, but we are not using it. It's speech therapy department that they are involved in it.
But then there are no published studies in the Indian context, so that is one of the drawbacks. That was the point for doing this study because we have a lot of studies on ABA per se, but not specifically focusing on manding tactics, tacting and ecoics or intraverbals.
Thank you.
Yes, ma'am. So novelty is the first thing is that this program is parent mediated. In a country like India, where we have only 4,000, 3,500 to 4,000 mental health professionals, and the disease burden is so high, we need parent-mediated programs. The clinician cannot be everywhere. We need to teach the parent to do the intervention and guide the parent. That is one thing. Other thing is for specific Indian population, there is no like culturally sensitive interventions for ABA, neither for ABA nor for verbal behavior approach. And mostly when people use verbal behavior approach, ABA, verbal behavior approach is not really on the list of modalities that they're using over the duration. So very less used. very less used in the country.
That's a parent. You saying parent-related programs are not there. There are nice apps which are actually giving a complete training for parents for ASD at home. So ASD Buddy is one of the program which is online available.
Basic understanding. So it was like parent management training. So you included parent as well for this training, and that is the main aim of the therapy. Any inclusion exclusion criteria for selecting parents, or it was like just consent. If they are giving consent, you are selecting. Okay. Do you think that?
But for the child.
Okay. Do you think that any the outcome or the training will get affected because of the parenting as well?
It could, but this is like obviously I'm saying this is case series. It's one of the first studies to publish, and
Okay, okay.
there's a lot of variables to
Yes,
control,
yes,
right?
yes, yes. So very specifically, you have gone with the okay.
Then if you keep on increasing, then what all variables will you?
Definitely, because those who work with the child population, major problem what we face is with the parents. And the parents, even though they show that consent in the session, they are ready to come, but the follow up and whatever the plans we are giving, they are not following it. So maybe they might say that they are following, they might give the reports that okay, this is happening, this is not happening, but we don't know what they are actually doing at the home, at home.
The qualitative aspect that I've mentioned is also from the parent report, but also from my therapy notes. So there was improvement, but also yes. So I'm currently posted at NIBID, and over there, parents do come from far away. These are very dedicated parents. Most of them who are coming to a setting like this from far away, leaving their homes and living in NCR just to get intervention for their children. These are highly motivated parents, all of them. So this is one thing that I would like to mention. Thank you, ma'am. Thank you, everybody.
Thank you. We'll now proceed to our next presenter. I request Ms. Shrija Swapnil to come up on the stage for her presentation. Good afternoon, ma'am. Good afternoon, everybody. I'm here to present a single case study on the topic Understanding the Psychosocial Underpinnings of Hyperkinetic Conduct Disorder. Hyperkinetic conduct disorder is characterized by a combination of severe hyperactivity, impulsivity, and conduct problems such as aggression, rule breaking, and defiance. Talking about the prevalence rate in India for ADHD, it is around 6.32%, and globally it is in a range of 4 to 10% because there's high heterogeneity. For conduct disorder, it was found that in India the prevalence is 4.5 to 14.5%, and for globally it is 7 to 9%. It is more commonly seen in boys with usual age of onset early to middle childhood. Hyperkinetic conduct disorder is often associated with academic difficulties, peer rejection, and increased risk of antisocial behavior in adolescents if untreated. In this present case study, the specific triggers, coping patterns, and contextual factors of hyperkinetic conduct disorder is identified using a single case analysis. The study aims to explore the developmental and psychosocial underpinnings of hyperkinetic conduct disorder, emphasizing how tailored interventions can improve behavioral and emotional regulation. These are my literature review. So, Cortes et al. In 2024 found high comorbidity rates between hyperkinetic disorders and conduct disorders, which shared deficits in inhibitory control, motivation, and emotional regulation. Fairchild et al. In 2024 found reduced amygdala and prefrontal volumes linked to poor emotional control and impulsivity. And he also stated neurodevelopmental overlap that exists between hyperactivity and conduct problems. Wang et al. In 2024 found impaired emotional recognition and reduced affective empathy in adolescents with conduct disorder, and deficits were linked to greater impulsivity and externalizing behavior. Then Karalunas et al. In 2023 quoted children with persistent ADHD had lower IQ scores and poorer executive functions, whereas higher IQ moderated symptom severity but not disorder persistence. The aim of the study was to assess behavioral, cognitive, and psychosocial functioning for diagnostic classification and intervention planning. The design used was single case study using quantitative and qualitative assessment methods. Here's a brief case summary of the child. Mr. K, a 10 years, 5-month-old boy from lower socioeconomic nuclear family studying in UKG, was brought by his mother with complaints of persistent disobedience, aggression, and socially inappropriate behavior. Since infancy, he had exhibited developmental delays and marked hyperactivity with an insatiable need for movement and destructive play. From early childhood, he displayed frequent temper tantrums, hitting, biting, and scratching when angry. He often wandered away from home and formed close association with much older boys in the neighborhood, gradually beginning to mirror their behavior, such as skipping school, using abusive language, and engaging in rule breaking activities. At school, he was consistently inattentive, disruptive, and defiant, leading to repeated grades and frequent disciplinary complaints. His behavior included teasing animals on the street, lying, and appeared unaffected by the reprimands or physical punishment. Over time, inappropriate sexual curiosity, deceitfulness, and rule breaking intensified, accompanied by low fear of consequences and superficial remorse. The family context was characterized by marital conflict between the parents, inconsistent discipline, and limited emotional supervision. Perinatal history revealed delayed birth cry and cyanosis, followed by global developmental delay in motor and speech milestones. On examination, he appeared restless and fidgety. Difficulty in maintaining eye contact was noted. Thought content revealed lack of remorse and guilt, thoughts of boredom, and provocation to seek social stimulation. Adequate fund of knowledge and functional level of abstraction was present with partially impaired social judgment and absent insight. These are the assessment tools that I've used with their rationale. So I've used Binet Kamat test for intelligence to assess the level of intellectual functioning of the child. I've used Vineland social maturity scale to ascertain the level of socio-adaptive functioning. I've used child behavior checklist to assess the behavioral and emotional problems in the child. Connor's parent rating scale was used to assess the level of inattention and hyperactivity and associated behavioral problems. Junior temperament characteristics inventory was used to understand the temperament and characteristics of personality in the child. And draw person test was used to build rapport and assess personality disturbances. These are the results across various domains. For the cognitive domain, it was found that the child has borderline level of intelligence and socio-adaptive functioning with marked inattention. In the emotional domain, it was found that the child has emotional immaturity and poor frustration tolerance. The projective findings are suggestive of emotional dysregulation. In the behavioral domain, marked hyperactivity was noted with pronounced externalizing behaviors such as aggression, impulsivity, and defiance. For the temperament, the child was found to have high novelty seeking, low persistence, and low harm avoidance. The projective findings also reveal low self esteem, insecurity, and poor self concept. I've used the biopsychosocial model for discussing the child symptoms. So, in the biological domain, because of time constraint, I couldn't add the family history, but the family history of suggestive of substance abuse in the father, in the paternal uncle, and in the grandfather of the child. There are also birth complications, like the child was born at 11 months, and there were also marital conflicts at that point between the parents, so it leaded to a lot of stress. And cyanosis was also present. There was also delay in milestones. For the psychological factors, borderline level of intelligence, temperament characteristics like high novelty seeking and impulsivity, low harm avoidance, and low persistence was found, and externalizing coping mechanisms were seen. And in the social domain, we can see that lower socioeconomic status, parental conflict, physical punishment used by father, lack of supervision, coercive interaction pattern in family and disengagement of father was identified. I've also used a behavioral model to explain his symptoms. So I've used operant conditioning to understand that the child has displayed hitting, biting, scratching people and throwing things when he was angry. This was followed by a consequence of no scolding or significant punishment by parents and giving in to the demands of the child, which led to the child displaying the behavior again and again, and he also learned to hit his peers when they were not accepting his terms of play. There was also an incident reported where the child was seen smoking bidi with his friends in the locality, which led to him being scolded and hit by his father. So this acted as a punishment and hence no further instances of smoking was reported. The habituation theory is also used, which talks about prolonged exposure to a stimulus leads to decline in reaction intensity or not reacting at all. So here in this particular case, exposure to verbal abuse at home. So the conflict between the parents. The child learns to normalize aggression and violence and stops fearing or resisting the same. Also, repeated scolding and physical punishment used by the father is leading to the child that the child does not fear scolding or punishment and shows no behavioral change. So while I was also interacting with the child, I asked him about how is his interaction patterns with parents. He said that वो मेरे को हमेशा डांटते हैं, so I don't care about it now. वो इतना डांटते हैं तो मेरे को कोई फर्क नहीं पड़ता. I've also used social learning theory and vicarious learning theory to understand this. So observation of behavior and its consequences in the natural environment and the analysis of the consequences to see if it's rewarding leads to the imitation of the behavior. So child observed his father being aggressive as a result of gaining position of dominance in the family. So he understands how dominance gives father decision making power in the family and act as per his wish. Hence the child learns that and imitates aggression at home and in his peer group. To conclude, this single case study illustrates how neurodevelopmental vulnerabilities reinforced by inconsistent parenting, family conflict, and maladaptive learning experiences contribute to the development of hyperkinetic conduct disorder. The findings emphasize the significance of understanding the psychosocial dynamics shaping behavior rather than attributing it solely to biological causes. Viewed through a biopsychosocial and behavioral framework, the study highlights the need of integrated, family centered interventions that address both emotional regulation and environmental reinforcement patterns. These are my references. Thank you. Any questions?
Conceptualization is great. The way you have presented the case and put everything in place is really nice. My only thing is that the hyperkinetic conduct disorders are not uncommon. We see quite a prevalence. Then why go for a single case study? Because it's the validity, generalizability is very weak in that case. Because what you are finally stating, it's only talking about one single case and dynamics. And also, this case is not having an intellectual level also. The child is already a borderline slow learner. So, considering this in the research perspective, it can have a very low generalizability.
So this is the first case and I still have to go in detail, and also because I wanted to get into the detail of one particular child, and also I'm planning to plan therapy for him and work with him and see a longitudinal study also with this particular child. Hence the case study.
What is the takeaway from this presentation? Like, what is something new that people are learning? This is really good. Right? So, what is it something that you kind of add to the knowledge? Something new that you found in this game?
Right.
Could you like share this?
Right. Ma'am, the aim of this study was to conceptualize the case and to plan on the intervention for this particular child. Right. So, because that is the reason why I've taken a single case study and gone into the detail of how he's.
What's the point of having this discussion?
So, conceptualizing it from the biopsychosocial model and looking at the biological factors that may lead, because there are a lot of studies talking about the biology of hyperkinetic conduct disorder. More specifically about both the disorders separately and saying that there exists a high comorbidity. Because hyperkinetic conduct disorder is also given in ICD-10, but it is not mentioned in DSM, and ICD-11. It's a separate category altogether. So there are studies talking about biology. There are studies talking about psychology at some aspect, but I also wanted to add the social angle to it.
Thank you.
Thank you, ma'am. He is on treatment. He is on treatment. He is taking medications. For this particular child, he is on treatment. He has been prescribed medications, and even after the medications, there is reduction in impulsivity and inattention a little, but the behavioral problems still continue.
Then you think that ID is the only factor and controlling factor.
See, definitely, I do feel that the prognosis, because of ID and because of the family structure, everything becomes poor in this case. Also, the conduct symptoms have started at a very early age in this particular case. So, I do feel that they are adding to bad prognosis.
Okay.
But
Yeah, okay. And one more thing. As you said, that child is in UKG and is a 10-year-old. Do you think does he really have like bottle intelligence?
no, I'll tell you the reason behind it. So when I interacted with the parents, they come from a lower socioeconomic status with not good level of education in both the parents. So till the age of 5, they waited for the child to be disciplined at home, and hence they did not decide. They were living in a village, so they did not decide to put him in school. And the decision to put him in school was only made because he was too indisciplined. So they planned कि ठीक है अब इसको school में डालते हैं, so that he becomes a little disciplined. But then the complaints further increased, and this was around the time of 2019. He did go to school for 6 to 8 months, and then due to COVID, they did not send him to school altogether for 1 year. Then they had to again put him to LKG, where he did not do his assignments, where he did not or did not do his work, and because of that, he had to repeat his grade. Hence, they shifted their school also, and they shifted the locality altogether. So now they are based in Noida. They had to come from their village to Noida just to discipline the child, thinking that the environment around might affect him and the school. So now they've put him in a government school where he is in UKG. So hence he's 10 and he's in UKG.
Really good they want the child to get educated.
Thank you. Is Miss Shubhangi Sharma here? No. Okay. Up next, we have our final presentation. I now invite Miss Himani Karnawat for her paper presentation. Good afternoon, ma'am. Good afternoon, everyone. So, today I'll be presenting my review paper on cognitive adaptation theory, exploring resilience through self enhancing beliefs. This theory is developed by Shelley Terror in 1983, which explores that how people cope with life challenges and traumatic experiences through adaptive thinking. This theory examines how individuals use beliefs and meaning in right. This theory examines how individuals use beliefs and meaning and perception of control to protect their mental health, especially during the times of distress and illnesses, grief and loss. Rather than denying the reality, CAT shows that people often reinterpret in constructive ways that restores their resilience through self-worth and purposes. In other words, we can say that our minds help us to heal long before other circumstances do. So the core premises of CAT is the cognition so the core premises includes the cognition as the adaptation of the mind. So it is deeply rooted in the theories of Darwin's evolutionary theory, suggesting that survival depends not only on the physical strength but also on the psychological flexibility. So CAT integrates these ideas and proposing that our thoughts themselves are tools for survival. Shelley Taylor did the groundbreaking work with people facing the life-threatening experiences and illnesses led to the development of CAT. So she observed that individuals often create self-enhancing beliefs, some realistic, some mildly distorted, to maintain emotional balance. These um, these beliefs help them find meaning, feel in control, and protect self-esteem, which in turn fosters the psychological resilience. So she argued that even if these beliefs aren't entirely accurate, they serve as a functional purpose and a flexibility purpose. So if individuals think that I can handle this, which motivates them adaptive behavior and emotional recovery. So CAT emphasizes that coping is not about pure realism, but about maintaining beliefs that perceive hope, meaning, and mastery. So the three pillars of the coping strategies are the search for meaning, regaining mastery, and restoration of self-esteem. So when we say the search for meaning, when people face with traumatic life experiences and adversities, they often feel that why it is happening to me and why it is only me. So this search for help to make sense in chaos, restoring mental order and predictability. So Taylor found that meaning making is often first step and the building block for the emotional healing. When we talk about regaining mastery, so adversities create helplessness in individuals. Regaining even small aspect of control, they feel that they are having something in routine and the problem can be solved in positive reframing themselves. So research by Thomas supports this, showing that perceived control significantly reduces the psychological distress. When we talk about the restoration of self-esteem, so difficult events often lower down the self-worth of an individual through positive self-compassion, comparison, recalling the past experiences and strengths of an individual. It rebuilds the confidence level of an individual. So Taylor and Brown found that the positive illusions, slightly idealized self-views displayed greater emotional resilience and lower the depression level in an individual. Together, these three pillars help individual to form mental reconstruction and reorganization experiences to maintain coherence and hope in individuals. So the cognitive coping strategies talks about the positive illusions and the motivation through persistence and adherence to treatment plan. So if an individual is having this positive illusion that an individual is feeling better and having that belief that they have the control over their adversities, they are motivated enough to go with the treatment and adherence to the treatment part. So empirical evidences also show that people with optimistic self-view and perceived control have better immune functioning and faster recovery rates in when they are facing with adversity or illnesses, and greater well-being are reported. These findings highlight the key insight of CAT that sometimes believing things are better than they are helps making them better. There are two theoretical basic foundational theoretical aspects that are the evolutionary psychology and Piaget's cognitive development theory. So when we talk about the evolutionary perspective, it is from a survival standpoint of view that optimistic thinking increases the persistent and cooperation and also social bonding, all essential for survival. Thus, they protect psychological mechanism in an individual. When we talk about the Piaget's developmental theory, it has two processes, that assimilation and accommodation. So aligning closely with CAT, after trauma, individuals altogether feel that there is even in the either they are integrated the event into the existing belief or they change their belief system to maintain the psychological coherence. So this shows that adaptation is a dynamic mental process, not a static one. So both the framework supports CAT claims that humans are wired to restructure the thought in ways that maintain emotional stability and meaning in their life. Applications in mental health. So through various studies, it was found that it helps in reducing the depression level of an individual. Also, it helps in the better glycemic control and emotional well-being in individuals with diabetes. Also, with cancer patients, as they have a sense of survival that they are getting better, and the unrealistic belief may hinder sometimes, but there is always hope in the individuals that they are getting better through the restructuring of this. So these studies collectively highlight that CAT is not limited to the theory, and it has a practical psychological framework that explains how thinking patterns shapes feeling and healing also. So motivational model and positive psychology. So building on the CAT researches that has been integrated with the self-determination theory and proposing that a motivational model of cognitive adaptation. So this model explains that the adaptive belief satisfies three innate needs of three innate psychological needs, that is the autonomy, competence, and relatedness. So CAT also aligns with the positive psychological aspects, especially the Seligman's PERMA model. So both emphasizes the well-being, and well-being isn't merely about the absence of the mental illness, but the presence of growth, meaning, and fulfillment. Thus, CAT forms the bridge between coping and flourishing. So CAT principles are being used in therapy to promote resilience, motivation, and adherence to treatment. So therapeutically, CAT inspires interventions including cognitive reframing, making meaning, exercises, and self-efficacy enhancement. Yeah. So in conclusion, that CAT provides a rich understanding of how individuals transfer from suffering to into strength through cognition. It also shows that resilience doesn't come from the external support, but life experiences. It also arises from the stories we tell ourselves. Thus, CAT reminds us to the realistic thinking keeps us grounded, but hopeful thinking keeps us moving forward.
And my questions from the audience, please.
So this is nice model, but any because you it's a conceptual framework that you have presented. Any hypothetical research study have you framed for this?
And today we are talking a lot about third wave therapies, right? So could you tell me what's the role, if there is any, and what could be the role of cognitive flexibility and psychological flexibility in this?
So today we are focusing on third wave psychotherapies, and also there is a lot more in the manifestation and aspects which are coming all together. That belief system, you need to have a belief system that you can do better in life. So when we are working with the cognition of an individual, we are trying to make the individual realize that there are potentials in the individual which they are losing or which they are lacking, which they are not able to function at well. So we are making that individual realize of their strengths, which are somewhere the individual is not using on a very efficient basis. So this through this cognitive adaptation, we can make these scenarios for the individual in such a way that the individual realizes their strength, and we build the insights that they have the strength to come up out of the strength.
All right. But also that these two terms that I mentioned, they are the core, at the core of every adaptation. So these are used for your resilience and adaptation. Okay. But thank you. Thank you.
Sincere thank you to all our presenters for their hard work and valuable contribution. I now request Dr. Deepika Srivastava
to kindly felicitate our chairpersons. I now request Dr. Deepika and our chairperson, Dr. Nishta and Dr. Tarana, to kindly present our speakers with their certificates. Takreem Malik, kindly receive your certificate. Mr. Sahil Ganesh, Miss Shrija Swapne, and Miss Himani Karnawat. So all of you can now proceed for directory editor. This is how was it? You were able to answer? Yes, Manisha Jha and Charlotte. He also Manisha Jha. All of